don't cut out.
Good morning. Good morning. Good morning. It's great to welcome all of you here to the American Enterprise Institute. We are going to be talking about the Patient Protection and Affordable Care Act. That's too many syllables. I won't say that again. I might refer to it as the ACA, the Affordable Care Act. Other people might call it Obamacare. Whatever you call it, that's what it is. This is a particularly auspicious moment for at least a couple of reasons. One is that apparently we have the latest statistics on how many people signed up. Of course, there's always a debate about what those numbers mean, but the administration says 8 million people, so they feel that they've reached an important milestone. The other auspicious aspect of this is that Congress is not in session, so we didn't have much competition. Let me introduce the first panel, and we'll get rolling here. The first speaker is Jim Capretta. Jim is with the American Enterprise Institute and the Ethics and Public Policy Center. He's spent a good long time on the Hill and at the Office of Management and Budget, and we'll have some positive things to say about reform, not necessarily the current one. Tim Jost is the Robert Willett Family Professor of Law at Washington and Lee University. Tim actually is well known for writing virtually on a daily basis blogs in the Health Affairs website explaining the incredible details of the latest incomprehensible regulations that HHS puts out. Ideally, we won't get that deep into it today, but who knows. And then Mark Pauly is the Bentheim Professor at the Wharton School at the University of Pennsylvania. Mark is well known to AEI audiences and has written many papers for us, and we're looking forward to what he has to say. So with that, let's start with Jim.
Oh, good morning. This is a great time to sort of take a snapshot at what's going on with the healthcare law. I think I would agree, though, with some of the commentators I've read recently, some of whom are very strong supporters of the law, that it's going to take much longer than the 3 months we've been into this to really understand the full implications of this. It's probably going to be a 2 or 3 year process before you can really figure out whether it's changed the insurance landscape in a way that's positive or negative, and the cost structure of the country in a positive or negative way. So we are very early into this to make some judgments, but we work at a think tank and we do conferences, so here we go. We're going to do it anyway, and so I read sorry, apologize for the small type, but there's just too much to cover in this, so I'll read it out to you. But I was very struck by a column that was written by our colleague here at AI, Ramesh Punaru, who wrote he's kind of summed up my thinking about this pretty succinctly. He sort of said, well, is this a success story or is it a story of survival? And I do think it really is much more a story of survival than it is a success story so far. So the thought process is, let's look back, think about if you were talking about the prospects for the healthcare law a year ago, and someone described to you a series of events that kind of goes as follows: that the Obama administration over the course of a 1 year period would unilaterally delay the employer mandate not once but twice, would take unilateral action to announce the non-enforcement of insurance rules on several million individually issued insurance policies, not once but twice, and now they're open and won't be, quote, subject to enforcement of the law for a 3 year period, whatever that means. Issued a series of exemptions to the individual mandate that are so vague and without meaning that it would appear to allow just about anything to be exempt. That was coincidental with a 2 month period where a multi-billion-dollar project to build a federal website and state exchanges essentially collapsed for 60 days, and then later became partially functional through a series of workarounds initiated by people who were not under federal contract but just kind of got flown in to help resuscitate the project. The back end still doesn't work and can't be used to pay subsidy payments to the insurance plans. after a taxpayer investment of, as I said, probably in the range of about $2 billion. 3 state exchanges are so dysfunctional that they're on the verge of being, having the plug pulled on them after an investment of federal dollars of upwards of several $100 million, $300 million, I believe, alone in Oregon. A little more than 2% of the U.S. population has enrolled into insurance through these exchanges, a program that would be smaller than S-CHIP, and about maybe a third of them are on the target population of people who were supposedly so bad off that they were previously uninsured because of previous arrangements. The Congressional Budget Office issued new estimates of the labor market effects of the law, indicating that in a 10-year period of time, and frankly, within a few years, 2.5 million Americans would drop out of the workforce because of the incentive structures of the law, and thus shrink the size of the working population by a noticeable percentage. Health spending, commensurate with the launch of the law, would return to a pattern that looks like it was previous to the deep recession of 2009, late 2007 through mid-2009. The latest estimates are that health spending grew in the fourth quarter of 2013 at a rate of about 5.3%, and in the period of February 2014 relative to the prior year of about 6.7%. This is the rate of growth is the fastest in many years, and there's lots of evidence now coming forward that we're in a period of pretty rapid health spending escalation. Then maybe the kicker really is just the ongoing evidence of what this means from a public perspective. Just some more, some of the more recent polling data would indicate that the sort of one measure of this would be, this can be asked in a whole bunch of different ways, so you're going to see all kinds of different polling data, but one that I think is most indicative of sort of really what's going on the ground is if you're asking Americans, do you hold a very favorable or very unfavorable view of the law? The very unfavorable in a very recent poll was 38%, and the very favorable was 21%. And those are the people that are most likely to act on their point of view politically one way or the other. So if one were to describe the healthcare law with these kinds of, if you had looked ahead a year ago and said that this was how the first year was going to look for the law, would this be viewed as a smashing success and everything was going great? Or would you view it as, well, it's off to a bit of a rough start, but maybe it survived so far? And I think the administration has done a very good job of essentially lowering the bar of success, jumping over it, and then celebrating with a exaggerated, 3-week-long dance. So, there's a lot more to be done here to see whether this is working or not. And it's going to take, as I said at the beginning, it's going to take a couple of years to piece through all of that. The second point I want to make has to do with what lies ahead in terms of what has been promised to the public in terms of what the law is going to deliver on. And these are CBO's latest estimates of coverage estimates for implementation just between 2014 through 2016, and what it's going to mean for sorting out of people's insurance coverage status. First thing to note is that the Congressional Budget Office latest estimates issued, a couple weeks ago, the numbers were probably, to be fair to them, developed, 6 weeks or so ago. They estimated that in 2014, the reduction in the uninsured would be about 12 million people. And that is comprised of a number of ups and downs, but they estimate that the number of people in the exchanges will be about 6 million people. That's probably going to be about where it ends up on average through the year. Remember, they might be at about 8 million now, but that includes a lot of folks who are likely not to pay their premiums throughout the full year. It also, in any given year, you're going to have turnover in the insurance system as people go and find a job with employment-based coverage and therefore leave the exchanges. The entry into the exchanges will be less rapid than the exit from them because of the rules that are set up for open enrollment. So you're likely to see that number shrink a little bit each month over time. On average throughout the year, 6 million is not a bad guess still. Medicaid, they have it a 7 million person increase relative to what it would have been absent the law. There's so much noise in the Medicaid numbers, it's hard to tell at the moment if they are quite at that point. I think they're pretty well shy of it myself. If you look at the data, you know, as of the spring of this year, it was probably an increase of 3 or 4 million people relative to what would have happened otherwise. By the way, many of those people are in states that didn't even expand Medicaid, right? In other words, there are people who are eligible for Medicaid anyway, but now have signed up because of the outreach, the advertisements, the general informational overload that's come about through the implementation of the law. More people have ended up signing up for Medicaid, even in states where they never even expanded the program. So 7 million, that's still, they have a lot of work to do to get to 7 million still. They expected the employer-based system to be essentially unchanged. They could be off on that one by a fair amount. That there might be some data coming forward saying that to avoid the individual mandate tax, there's been a little bit of a sorting out where people could and who could go into the employer-based system have done so to avoid the tax. And that number may actually go up by a fairly large positive number. And then non-group coverage, a reduction of 1 million, you know, again, that one we'll have to wait and see. There's been a lot of cancellations, there's been a lot of sorting out going into the exchanges. There was continuations because of the president's last-minute changes. It's going to take a while for that number to sort out as well. Now, looking ahead to 2016, I think the really important thing are two numbers. Obviously, the bars that change the most in a 2-year period. They're expecting that the success of the exchanges is such that by 2016, an additional 18 million people will have signed up in the exchanges on average in 2016 relative to 2014. That's a big change. That's a big change. And I know they're going to refer to and say, well, this is what happened in Massachusetts, et cetera. But still, that'll take a lot of work to convince that many people to go into the exchanges. And the premiums offerings in the exchanges would have to be pretty attractive to get that many people into the program. They also are promising a 25 million person reduction in the uninsured in a 2-year period. Again, that will be a big shift, and will take a lot of additional signups to make that happen. By the way, in the ensuing years, the enrollment season won't be 6-month-long protracted process. It'll be probably a 45-day or so process in most instances. Now, what's the maybe the most important thing to think about with respect to all of this is the individual mandate tax. This is, again, I think from the perspective of both supporters of the law as well as opponents, probably one of the key provisions, and still a little bit unknown exactly how it's going to play out. You know, the way the Congressional Budget Office estimated the bill may be actually the way it plays out, which is that the public perceives this as a new legal requirement, that they have to sign up for health insurance, that the country has now enacted a law that says, hey, if you don't sign up for health insurance, you're sort of acting lawlessly and you got to pay a penalty. The other way to view the individual mandate tax, and the way actually that John Roberts wrote it up and allowing it to continue forward, was as an optional tax. You actually have two lawful choices. You can either buy insurance that the government says is approved insurance, or you can pay the tax instead as an option. A lot depends on how the public eventually perceives this thing. Does the public view it as, hey, now I really have to do this, otherwise I'm acting lawlessly, and therefore there's this sort of aura of obligation that kind of comes around with the individual mandate tax? Or does the public say, it's really not worth it for me to pay these huge premiums, I'll pay the tax instead, that's perfectly acceptable and fine thing to do? A lot depends on that, because for a lot of people, if they think about it as the latter choice, paying the tax instead, they would save a lot of money. The question is whether they feel like it's wasted money and they'd rather just get the health insurance instead. So a lot depends on how that's perceived, and the numbers that CBO has reflected on this chart in a sense assume this aura of compliance is going to sweep over and everybody will eventually sign up for coverage that didn't in 2014. And so we'll see. It's a big question. But one of the implications really is for 2014, just look at the numbers again, think about those numbers. You have about, as of now, CBO estimates that about 42 million people will remain uninsured in 2014, and that will result in a payment of the uninsured tax of about $2 billion in the 2015 tax filing season. Now, the uninsured tax doesn't apply to non-filers of income tax. So if your income is so low, below about, in rough terms, $10,000 for an individual, $20,000 for a joint filing household, you don't pay income taxes, and therefore the mandate tax doesn't apply to you. Moreover, if you would have been eligible for Medicaid in a non-expansion state, they will exempt you from the individual mandate tax. By the way, we also have all those other exemptions I mentioned but didn't really describe earlier. Also, of course, it doesn't apply to people that are in the country illegally, and therefore, not really in the tax compliance system anyway. So there's a large number of that 42 million who won't be subject to the individual mandate tax. But it's still in the many millions and millions of people who are uninsured and have a high enough income to file taxes and pay the tax next year. I think a very big question, I don't know the exact number, and I'm trying to ascertain what it is, but just an eyeball of the way it looks, it could be in the range of 10, 15 million people who are subject to the individual mandate tax for calendar year 2014. That's an awful lot of people who are now going to be subject to a 1% penalty on their household income, or $95 per adult if it's lower. So where does this come out? I do think this is a sleeper political issue that's going to play out over the spring, summer, and fall as people sort of dawns on a lot of people, hey, wait a second, I'm going to have a lot of constituents who are going to end up paying this tax next spring, and they may or may not realize that this is about to happen to them and how much it's going to cost, et cetera. And given the pattern of, if I had to describe the way the Obama administration has approached implementation, it is to try to take every difficult political issue they can off the table. And so I think, keep your eye out, Joe Antos predicted this months and months ago. He said to me, you know what, I think they'll exempt everybody from the individual mandate tax just after open enrollment season closes, right? Which would be the most politically astute way to go about this. Tell everybody they're going to apply it to them, make them sign up for health insurance, and then after the open enrollment season say, oh, by the way, you're all exempt from the tax this year because, well, it's the first year and we're just getting started, et cetera, et cetera. So keep your eye on that because I think it has big implications both for 2015, the midterm election, as well as 2015 and 16, and whether the individual mandate, whether they really have the wherewithal to follow through and apply the individual mandate tax to tens of millions of people. I think I'll stop there. Thanks.
Thanks, Jim. There's another reason why this is a bad year to try to collect that tax, and that is that according to the law, you've heard of that, the tax is supposed to be applied to anybody who doesn't have insurance for 3 months or more. Okay, so the administration was selling insurance in April, and that insurance, if you bought it in April, it wasn't going to start until May. So the way I count the calendar, they've already, in essence, exempted everybody because they can't apply the tax to people who they said, come on in later. We'll let you sign up. So I think this is one of the many difficulties, but there are plenty of others. Tim, take it away.
Thank you. And thank you for inviting me. I think I'm here as the supporter of the Affordable Care Act. I'm not going to argue with Jim on a point-by-point basis. I agree with him on a lot of what he said. I disagree on other things and probably on an overall perspective, but I'm going to actually talk about something a little different. The Affordable Care Act, as has often been noted, is a very lengthy and complex piece of legislation. The senators that drafted the Affordable Care Act, and this included Republicans as well as Democrats, there were over 100 amendments offered by Republicans that were accepted in committee, but these senators saw this as their only chance in a generation to really reform the healthcare system. So there is a great deal in this statute that we're not going to be talking about today. Reform of Medicare, of Medicaid, fraud and abuse provisions, quality provisions, long-term care, many other things were addressed by this statute. I think it's fair to say, though, that the people who drafted the Affordable Care Act, their main goal was to expand coverage to Americans who lacked a secure source of insurance coverage. Nearly 50 million Americans lacked insurance coverage in 2009-2010 when the statute was adopted, and Congress intended to give them an opportunity to get covered. The legislation was based on 4 assumptions about health care coverage that I believe to be objectively true, although there are probably some in this room that would disagree with me. The first is that health care is on the whole beneficial. People are better off with it than without it. Secondly, is the assumption that people with health insurance, either public or private, have better access to health care than those who lack insurance. A third assumption was that health care costs are heavily concentrated in a small number of people in any given year, and that insurers in unregulated markets will avoid covering these people if they can, or at least rate them up to try to cover their risk. The fourth assumption was that given the distribution of income and wealth in the United States and the cost of health care, private health insurance is simply unaffordable to many Americans. The Affordable Care Act attempted to make health insurance, and thus health care, available to all American citizens and legal aliens. In part, this was done through the expansion of Medicaid coverage for low-income Americans, although a remarkable exercise of judicial activism on the part of the Supreme Court has blocked Medicaid expansion in about half the states. But expansion of insurance coverage is also being accomplished by the revolutionizing of the nature of private health insurance. Private health insurance in the United States has historically been sold in 3 markets: large group, small group, and the non-group or individual market. Many Americans, particularly in large groups, are covered by self-insured plans, which are technically not insurance, but which most employees, I think, believe to be insurance. The large group market was functioning fairly well for most people covered by it before reform. Costs were high, and coverage was always precarious because loss of employment meant loss of coverage. But as long as an individual was covered, coverage was reasonably comprehensive. The small group market functioned less well, particularly for very small groups, and the individual market was dysfunctional for many participants. The ACA will affect all insurance markets, but in fact, insurance markets will continue to evolve and would have even without the ACA. Healthcare costs will continue to increase, driving premiums up. Employers will continue to move towards higher cost sharing and imposing wellness programs on employees, and don't get me started on wellness programs, and perhaps move increasingly to private exchanges. Narrower provider networks may well move up from the exchanges to employer coverage, and all of these changes will have significant effects on employees as well as on the providers who care for them. The greatest impact of the ACA, however, will be on the individual insurance market. Historically, the individual market has been a residual market for those unable to obtain employer or private coverage. It has been characterized by health status underwriting, with denials of coverage or uprating of premiums for those with health problems and pre-existing conditions exclusions, very high deductibles, transitory coverage with 60% losing coverage in any given year, high administrative costs, annual and lifetime limits, and limited coverage for some benefits. It also is a very small market, accounting only for about 4% of the total revenue of America's largest publicly traded insurers, some of who probably have more to lose from the failure of states to expand Medicaid than they do from anything that happens in the individual market because of the Affordable Care Act. The ACA has changed the individual market dramatically. In 2010, the ACA restricted annual and lifetime dollar limits, required coverage for preventive services, banned rescissions, and required internal and external review for coverage denials. In 2011, medical loss ratio and rate review requirements went into effect. But the biggest changes came in 2014 with the essential health benefit coverage requirement, the ban on annual limits, a ban on health status, gender, and durational underwriting, and limits on age and tobacco underwriting, and a ban on pre-existing condition exclusions. These changes, of course, were supplemented by the individual responsibility requirement, the provision of premium tax credits and cost-sharing reduction payments, and opportunity to purchase health insurance through the exchanges. These changes have given access to the individual market for persons who were never able to access it before, either because of pre-existing medical conditions that excluded them from coverage or because they simply could not afford coverage. The individual market, including exchange, off-exchange, 2013 renewal, and grandfathered plans, has grown significantly over the past year and will presumably continue to grow. Many participants in the individual market have reportedly faced increased premiums. For some of them, insurance coverage has become less affordable, in fact, a fact that has received wide coverage in the media. It is important, I believe, to understand why premiums have increased and will continue to increase. Increased premiums are due in part to a richer mandated benefit package. I do not believe that in most states this is really a very significant factor. Most of the 10 essential health benefits that are covered under the Affordable Care Act were in fact covered by most individual insurance policies prior to 2014, including the benefit categories that account for almost all of the expenditures: inpatient and outpatient care, tests, imaging, prescription drugs. Pediatric, dental, and vision and habilitation care were not covered by many plans in the individual market prior to 2014, but these are very small ticket items. The biggest new requirement is probably maternity, which was not covered by about half the plans in the individual market prior to 2014, but even that accounts for maybe 3% of premiums. It's fashionable in some circles to criticize the ACA for imposing bloated coverage packages on unwilling Americans, a phrase that I lift from a quote in an article a day or two ago. But that's not what's driving cost-benefit price increases. A bigger ACA change in the non-group market in most states, although not in all, is an increase in actuarial value. John Gable's study published in Health Affairs last year found that over half of the policies in the individual market prior to 2014 were what he then called tin plans, what are now being dignified to copper plans, which is plans that have higher cost sharing than bronze plans. The higher actuarial value required by the ACA increases premiums, but it also increases coverage. So for some people, this is a move in a positive direction. For others, it increases their costs. Part of the increases imposed by the Affordable Care Act come from increased fees, the reinsurance 90/10 and exchange user fees. These impose a significant cost on health plans across the market, $10 billion this year for the reinsurance fee, $8 billion for the 90/10 fee, but they vary by carrier and market, and most of these fees will not be borne by the individual market. A much bigger factor increasing premiums is the change in the nature of underwriting, the end of health status underwriting and pre-existing condition exclusions, and the elimination of gender and durational underwriting and the limits on age underwriting. This will obviously increase premiums for young people, could decrease premiums for older people, but it really increases premiums for everybody because you have people coming into the market who were not in the market before, people who were on COBRA, people who were in high-risk pools, or uninsured people who simply couldn't get insurance because of their health status. The impact on the market varies from state to state depending on their pre-existing rating requirements, but undoubtedly this is a big factor driving increases. And then finally, medical trend is going to continue to be probably the biggest factor, or one of the biggest factors driving increases. Medical trend has been growing at historically low rates for the last 3 or 4 years, probably the lowest rates in my lifetime, but it is now picking up. And there are a lot of reasons for this. Just one factor, though, that I think is worth recognizing is the cost of Sovaldi, the Hep C drug that has just gone onto the market. United Healthcare spent $100 million on Sovaldi in the first quarter, and right now there's only about 1% of the people with hepatitis C who are being treated. $1,000 a pill, $84,000 for a course of treatment. I calculate that the cost of Sovaldi for this year is probably going to be about half the cost of the reinsurance and 90/10 fees. So, do we want to do that? Should we maybe control the prices of drugs? That's a discussion we need to have, but let's not just say the ACA is the only thing driving up premiums. Of course, other features of the ACA make health insurance more affordable. The premium tax credits, cost-sharing reduction payments, dramatically reduce the cost of health insurance and health care for many people. Narrowing in provider networks and reduction in provider payments will reduce the cost of many plans. Increased competition in some markets, and there's a lot of noise about more insurers wanting to get into the exchanges next year, may reduce the cost in others. Reinsurance reduces the cost significantly in the individual market. It's probably going to, for this year at least, decrease the cost of coverage by 10 to 15%. In the long run, at least, insurers will face lower administrative costs because they don't have to underwrite anymore, and their marketing costs should decrease as well. The ACA also, I believe, has the potential to stabilize the non-group market. The market has historically been highly unstable and will continue to be as people move into and out of the non-group market from Medicaid, from the employer market. But the combination of the premium tax credits, individual mandate, and open enrollment periods could make individual health insurance more of a long-term home for people who do not have other coverage opportunities. This could expand the market, potentially eventually resulting in the movement of Americans from the group to the individual market, a move that some in this room have advocated for a long time. The ACA's strategy of commandeering private markets to serve public ends, however, is fraught with danger, and I think a lot of the litany of problems that Jim went through in his presentation reflect this. Insurers naturally resist taking on risk. It's just like gravity, and they're endlessly creative in their approaches to avoiding it. We're already seeing insurers designing benefit and cost-sharing packages to deter high-cost enrollees from enrolling, imposing tighter medical management techniques to avoid paying claims, and offering ACA-accepted products such as short-term limited duration or fixed dollar indemnity packages, which Sarah Cliff wrote about this morning, to try to get around the ACA. I believe that the premium stabilization programs are going to have a major effect on punishing insurers who try to avoid risk or rewarding insurers who embrace it, but making these programs work is going to be very, very difficult. We also see insurers turning to narrow networks to reduce their costs and possibly deter high-cost enrollees, and addressing this is going to require further regulation, which the NAIC, where I spend a lot of time, is actively talking about right now, as well as requiring greater transparency. The most important point to me, however, is that the ACA is in fact working as intended. It is causing significant redistribution in insurance markets, to some extent from men to women and young to old, but primarily from from healthy people to unhealthy people, and from higher income people to lower income people. This is what it was supposed to do. The repeal and replace proposals so far proposed would not do that. In fact, some of them, I believe, would move resources in the other direction, from the unhealthy to the healthy and from lower income people to higher income people. Health savings accounts, association health plans, sale across state lines, malpractice reform, pre-existing condition high risk pools. None of these proposals would really address the problems that the ACA is intended to address. Distributional questions have lots of ramifications for public health, for opportunity, for productivity, but ultimately I believe they raise questions of equity, of fairness, of morality. Should everyone only be responsible for their own risk at any given moment, or do we have obligations to each other for mutual aid? The ACA says we're all in this together. This presents us with a number of questions. Can you turn a market-based, actuarial, underwritten insurance market into a social insurance program? Would we be better off with a real social insurance program? Are there ways of structuring the changed markets that provide broader benefits, perhaps structuring cost sharing so that those with lower medical costs see more benefits while those with higher medical costs are protected? Maybe we need to create a donut hole. Or are we better off with the old system that simply excluded 1/6 of the population? The debate about reform, I believe, needs to move beyond anecdotes and address these questions. I am hoping that as millions of Americans become covered through exchanges and Medicaid, we will have an opportunity to do so, and I thank you for allowing me to share my thoughts on this.
Thanks, Tim. Mark?
Thank you. Well, I think I volunteered, but somebody had to do it, to talk about the ACA and Obamacare, not in this year or next year, but what I call the moderate future. And I guess if you nailed me down to dates, I'd say something like 2016 to 2020. I'm going to talk about that. And there's my rhetorical title. Armageddon, Nirvana, or a bureaucratic backwater, because you need a bad guy when you give a talk, and I'm actually going to pump for bureaucratic backwater as the most likely outcome of Obamacare, neither Armageddon nor Nirvana. I do not think, for reasons I will get to, that it represents government takeover of 1/5 or even 1/6 of the economy. I also do not think, some people have alleged, that it represents a total transformation of the U.S. health insurance system from a wholesale to a retail level, or as my colleague Zeke Emanuel suggests, that it's going to wipe out group insurance for all but 20% of the largest firms. I think it's going to be a much smaller deal, and I will try to offer the reasons why. This is, I guess, basically what I just said, but as a professor, you always have to write down what you're planning to say so the students don't come up afterwards and ask you, what did you say? So here's what I'm going to say and will say. So I'll show you the numbers in a minute. I think they're striking. The fraction of the U.S. population directly affected by by what I regard as the core parts of the ACA, the subsidy and insurance reform parts, is actually quite small. Slovenly journalists can always write millions of Americans are affected, or if they want to be cautious, tens of thousands of Americans are affected, which is certainly true, but relative to the number who are not directly affected, that number is quite small. I'm not going to talk about Medicare. I think the parts of the ACA that deal with Medicare would have happened anyway, had to have happened anyway without the rest of the ACA, so I'm not going to talk about that. I might also mention, just to make Tim feel better, I am also a supporter of the Affordable Care Act, or I should say a qualified supporter, My view is we're better off with it than the status quo ante, but I think there are a lot of things in it, some of which are meritorious, one of which I'll talk about, but some of which are the dumbest possible way to do a good thing. So that's the qualification, but I still think we're better off with it than without it. And so I don't know about repeal and replace, but I do think revision, well, it's already happening de facto on the part of the administration, as Jim mentioned. Most of the revisions the administration has made are actually ones I would favor, so bring it on. But back to my main argument, the proportion is relatively unaffected. And at least the argument I'll make, my econometrics professor said when you make a forecast, you can say a number, you can say a date, just don't say them in the same sentence. But I'm going to stick my neck out a little bit more here and say, and I'll give you a little bit of the reason why in a minute. I think that at least for the state-based exchanges, and who knows for the federal exchange, I think in the future, the core parts of the Affordable Care Act, the subsidies and at least insurance provided by the exchanges, will look very much like Medicaid looks like. It has a lot of the characteristics. And as I've said, as I wrote down here, it looks to me like Medicaid light. I've studied Medicaid a good bit through my whole career, along with Tom Granneman, and I characterize it as a modest but modestly irritating government program, and I think that's maybe what the ACA will look like. Having said that, though, as a professor and as an economist, I'm required to say, on the other hand, a few features may be a bigger deal. One is the Cadillac tax, and the other is what I call non-neutral effects on employment-based coverage, and I'll try to be an equal opportunity insulter here and criticize private exchanges as well as public exchanges. Here are the numbers. My assistant put these together in the best way she could, but you really should look at the bottom line, literally, where we tried to discuss kind of the maximum potential fraction of the population who could be directly affected by the ACA, the potential, and then maximum and minimum in the short run. That's like 2014. Those are the numbers Jim was talking about, depending on whether you believe the CBO or not, or some of the other estimates. And then that long run thing was my attempt to come up with round numbers. They actually come pretty close to those CBO numbers, which I actually didn't look at. But the basic story, I'll talk about the largest fraction of the population. Well, there are really two categories: 40 million uninsured people taking out the illegal aliens who are not allowed to participate. And then, again, we don't really know, surprisingly, how many people bought individual insurance, but 15 million seems to be a reasonably good ballpark number. So you get 55 million people there, less than 20% of the population, 17% of the population. And if you go to the minimum estimates of who will end up participating and actually paying for their insurance in 2014, you're down to 5.5%. A long-run equilibrium number, a percentage of the population who would be directly affected, I wrote down 12%, I'd say plus or minus 2%, but as a reasonable guess. Depending, fundamentally, the most important thing here is whether the fraction of the uninsured, whether it'll be cut by a half, 40% or 60%. I don't really have a personal prediction there. One other thing I'll mention, I couldn't quite fit it on this chart, but I think it's kind of important. We hear, although probably hear a lot more real numbers today, that's why I come to Washington, that the people participating in the federal exchanges, the great bulk of them are receiving subsidies. The unsubsidized, individually insured are not participating in exchanges. They're going to the alternative individual market, and some are just keeping the coverage they already had if they were allowed to do it, and others are buying there. And so I think that group is kind of in between. It's affected, of course, by the community rating and the minimum medical loss ratio rules, but it's not affected by the other things that exchanges may or may not be doing. So that's kind of an intermediate group. But the group that's most directly affected are those in exchanges. Oh, and I should also say kids there should have quotes around it. Those are kids from 21 to 26 who got on their parents' plan. Okay. Right, right. So here is what looks, part of the background for this is a meeting we had at Wharton, a joint venture actually between Wharton and the law school at Penn, where we're studying the federal, not the federal, we're studying the exchange, the whole process of insurance exchanges. And we had, I think, about 10 people from different states come and talk about what's going on. And as I said, I've studied Medicaid a lot, and I was just sitting there thinking, these all sound like Medicaid people. All the sorts of things they talk about for the entire part sounded like Medicaid kinds of considerations. Now, that may be a selective sample, and again, we're not quite sure what the federal exchanges were doing, but sure sounded like Medicaid to me. And of course, indeed, many of them either had come from the Medicaid bureaucracy or were on loan from the Medicaid bureaucracy, which kind of makes sense. Medicaid in states is charged with doing things like determining income levels for eligibility, and that's part of what has to happen in exchanges. So if anybody knows how to do that, and it's not clear anybody does, but if anybody knows how to do it for the new population, they do. A second characteristic, this may be a little too snarky on my part, but it's sure the impression I got, was that the way they talked about the people that were signing up were kind of a master puppeteer perspective. We want to get these people to do what we know they ought to do. I guess the antithesis would be what my Wharton marketing colleagues would talk about. These are our customers. We want to please them. We want to choose a set of offerings that will be highly attractive to them so that they'll want to go get it and spend their own money, not that we have to somehow trick them into it or drag them into it or reach out to them in additional ways. We're going to persuade them to take a product rather than have a product that sells itself. Another characteristic, Tim mentioned this as well, are many of the products that are offered in exchanges are narrow network products, probably narrower network products. I know they're spreading everywhere, but they seem much more stark than the narrow network products being offered in the rest of the private market. And for all sorts of reasons, and part of this is the reason for the narrow network, it's designed to keep payment levels down and to keep costs down, particularly to keep physician reimbursement down. So that's what it looked like. What's new, nothing is perfectly parallel. So there are larger doses of federal funding that are part and parcel of health reform. For the newly enrolled in Medicaid, a much larger federal share, at least in the short run, than has been true of traditional Medicaid, and substantially larger federal subsidies to the people participating in exchanges than the federal subsidy that was represented by the tax exclusion. So there's a lot more federal money sloshing around. And then, of course, there's the money sloshing around to make the master puppeteers be able to put on their show, which Jim already mentioned. These are narrow networks, not Medicaid. I guess my view of what's going on here, it goes something like this. Under old Medicaid, fee-for-service Medicaid, payment levels were set low. People eligible for Medicaid had nominal coverage that was the best of any person in the country, virtually no out-of-pocket payment, but they had to find a doctor who would treat them. In a sense, demand-side cost sharing was wiped away, but supply-side cost sharing was quite substantial. And they had to go find some doctors who would treat them. A narrow network, in my conceptualization, identifies the doctors willing to take Medicaid-type payments, and at least makes it easier then for insurers to find the people who would be willing to see them for whatever kind of care they're going to be willing to provide for that kind of money. There is a fear of worsening physician shortage. I know a lot of opponents of the ACA are worried about that. I just wanted to say here, I'm going to give you some things to worry about, but I don't lay awake nights worrying about physician shortage affecting me, particularly if exchanges take the form of narrow networks. The people in exchanges will then only be clogging up the practices of those doctors who are part of the narrow networks, and since I don't plan to be part of a narrow network, I'm going to be fine. Till I go on Medicare, then I'm terrified, but that's for a different reason. We also know actually that Medicaid managed care doesn't seem to make much of a difference compared to Medicaid fee-for-service. Work of my colleague Mark Duggan shows that. But there is going to be a difference, certainly for people in the exchanges, to the extent that, especially that they choose bronze and silver policies. There's still going to be, I think, on the part of the exchanges and the people who run them, a desire that the plans emphasize coordinated care, patient-centered medical homes, and all that sort of thing. And here is something to worry about. How do you coordinate care in the face of relatively high consumer out-of-pocket payments? Effectively, an out-of-pocket payment is a bribe to the patient not to be adherent to what the doctor recommended if what the doctor recommended is expensive. And so this is going to kind of double up the problem of care coordination. I actually believe there's a lot of imaginative solutions to that, but it's really an interesting problem. I've mentioned about the solicitation of new customers. We know, though, from the state Medicaid programs that their desire to sign up or retain people ebbs and flows depending on the state of their fiscal status, and so one might expect the same thing to happen. And then finally, this last point is kind of important. The exchanges, I think, arguably will have view them and do view their obligation as one of holding down spending growth. And of course, there's also the provision in the law that allows people to challenge unreasonable increases in premiums. And we at least I think that the main driver of spending growth and the main reason it's slowed down lately has been because of the introduction or non-introduction of beneficial but costly new technology. In the heyday, particularly in the pharma sector in the late 1990s, new products were coming out all over the place. They were expensive, of course, because they're patent protected. That's what patents are for, to allow people to charge monopoly prices. But until Sovaldi showed up, we were actually in kind of a dry period in the pharma sector, and pharmaceutical spending growth dropped like a stone. That's the good news. The bad news, of course, is there weren't many good new products, so you have to be careful what you wish for. Okay, well, I want to say just make a couple of quick comments about some other dimensions. So this is the Cadillac tax and employer behavior, and just to get down into the weeds a little bit, of course, the benchmark numbers here, which I have to write down so I can remember, are in 2018, you'll have this 40% excise tax imposed on group insurance if the premium for an individual is higher than $10,200 and family $27,500. In a somewhat complicated way, that's tied to the consumer price index, which is a little weird because premiums are not a price. They're price times quantity of care that the insureds are receiving. But still, if you are a believer, as some people are, that we have a new normal, you might think that the slowdown, at least that we thought we were seeing, might mean that the Cadillac tax will become less material, and it might be. But on the other hand, it might speed up. Still in all, there's a couple of some comments I think that are important to make about it. The first is what economists believe and what most other people don't, but we still think it's important to say. Although the tax is nominally imposed on insurers, then presumably will get shifted back to employers. Economists believe the tax will come out of worker wages, though it's in a much less well-designed way than if you just cap the value of the tax exclusion. I do have to say that. I say that at every speech I give. So I do have to say that. The initial impact, at least according to results by Brad Herring and others, is going to be on a small number of employed people. But if the premium growth grows much more rapidly than the CPI, it will eventually affect a much larger number of people, and that's why there's a lot of wailing and gnashing of teeth in the benefits community. But the future impact does depend on whether the growth does or does not outpace that CPI target. So again, if you believed in the new normal, and you thought spending growth had slowed, we know healthcare spending growth has slowed. It hasn't slowed so much. I mean, everything has slowed in the recession, but it actually did slow relative to GDP. So then maybe we don't have to worry about the Cadillac tax. But if we're back in the trajectory that Jim talked about of rapid growth, then high-priced patented technology will continue to grow, and it's not available in exchanges. So the question to be raised here is, will the Cadillac tax cause people to shift away from group insurance to exchanges? And I guess my belief is probably not, for two reasons. First, the dollar amount of the tax savings from getting a tax exclusion for a middle income and upper middle income person compared to getting no subsidy if they went to an exchange is quite substantial and is not going to be changed by whether or not the tax hits. That would just enhance the subsidy even further if it weren't there, but at least whatever is currently offering incentives for people to take group insurance rather than go to exchanges, that dollar amount is not going to go down. It just might not go up as much as it otherwise would. Creative accountants might find a way to allow people to get some of the tax exclusion advantages in exchanges, but that would just make it neutral. Perhaps more importantly, though, if we do have an acceleration of growth because of beneficial but costly new technology, a key issue will be, will the exchanges be willing to offer that new technology on terms that consumers will find attractive? And I suspect they won't, because their job number one is to keep their premiums down. So the person's choice may be between continuing with group coverage, which may pay for the new technology, and switching to an exchange which won't pay for the new technology. And I think health is more important than wealth, so I think middle-income people will probably not be attracted to an exchange because it's cheap if it doesn't offer them the kinds of access to new technology that they prefer. Sorry, I'm just going to talk about the last point. The last point is a more serious issue, and then I'll wrap up, that has bothered me for a long time, and I have a perspective piece in the New England Journal last summer discussing this. The issue is, what about group insurance generally? First, so you don't have to worry all that much, there has, of course, been some discussion by some employers about how they're going to change part-time versus full-time workers in order to avoid the penalties that are imposed by the employer mandate. The employer mandate, of course, has been postponed, and if it never comes back, as far as I'm concerned, that'll be too soon. But nevertheless, even if it does, according to our calculations, it would only affect the lower income, or uninsured workers rather, in large firms, because those are the only ones who will be affected. And there's only about 5 million of those. Millions of Americans, of course, but a tiny fraction of the total population and a tiny fraction of the population getting group insurance. So that's the good news. There's, of course, some issues if you are a stockholder in Walmart or Darden restaurants or firms that employ a lot of low-wage, uninsured part-timers or potential part-timers. But overall, that part's not much of a big deal. What is a much bigger deal, however, is reflected in the datum that there are 50 million lower-income people who are getting their insurance in large firms, currently getting as a tax break only the paltry tax exclusion on a $4,000 policy. That'd be about $600. Whereas if they could go to an exchange, say at 200% of the poverty line, they could get a $2,500 subsidy. $600 subsidy if I'm the janitor at Microsoft, $2,500 subsidy if I can somehow get to an exchange and qualify. It seems to me that's a terribly destabilizing thing. From a political point of view, we've already seen the Union Health and Welfare Fund saying, well, why can't our people get the big subsidies when they're low income? Because after all, we're not greedy capitalists, we're nice unions, and we're providing insurance coverage as good as insurance coverage in exchanges, so why limit it? There'll be that kind of pressure, and there'll also be the economic pressure to carve out into small firms or low-wage firms those workers who are currently basically being mistreated by the asymmetry of the subsidies that we provide to lower middle-income workers. Because I have tenure, my solution to this problem is to make generous subsidies available to all lower middle income workers, but I realize that has a substantial budgetary consequence, but that's nevertheless, I think, very important. So to sum up, I think the issues, largely speaking, that are associated with the Affordable Care Act will not appreciably touch the great bulk of Americans. The president would have been right if he'd been a little less precise and said, you can probably keep kind of your insurance if you like it, as opposed to saying period, but that's at least it looks to me roughly true. There may be some changes that are associated with the implementation of the Cadillac tax. I have to say beneficial changes from the viewpoint of economic efficiency, because it may help to avoid overly lavish plans. There may also be some destabilizing and I think dysfunctional changes associated with the differential subsidization of lower middle income people in exchanges relative to the purchase at the group. One last comment. What could, of course, make my predictions wrong about the relative stability of employment-based coverage is if the exchanges actually were terrific in terms of the opportunities they offered. And that could be the case. If Uncle Billy ran your benefits department at your firm and it was all messed up, it's possible that an exchange may do much better. But I have a feeling, both with regard to public exchanges and to private exchanges, there's an awful lot of the pixie dust hypothesis going on, where we imagine that they'll just be a wonderful thing, and people will find them so much more attractive than what's currently available at a well-run benefits department of a large firm with large resources, with a lot of money at stake in keeping their employees happy. And I guess I remain a skeptic of whether there's that much likelihood of a substantial improvement. Thank you.
Thanks, Mark. Uncle Billy, well, I think I've met him. Why don't we see if the panelists have any comments they'd like to make, and then we'll go to the audience. So, Jim?
Well, it's been a very interesting conversation. Thanks to Tim and Mark. They both made excellent comments. I guess I want to mention a couple things about the Tim mentioned a little bit about the debate of the original enactment and what the goal was, and replace plans, and whether they would meet the goal of some of the things that the authors of the bill were seeking to do in a better way or worse way, et cetera. I think it's important to remember that, first of all, there's a lot of hyperbole around the issue of the uninsured that no matter how many times we say it, we still have to kind of come back to it, which is, Tim mentioned that 1/6 of the population was, quote, left out of the system. And it's obviously a much more complicated situation than that, that the 50 million people that are measured by the Census Bureau as being uninsured, first of all, it's not a static number. If you actually look at the number of people that are uninsured over a long period of time, the number is much smaller. So there's a fair amount of churn that's going on in the insurance system. Moreover, there's a number of illegal immigrants that are counted in the 50 million number. Moreover, there's probably about 10 million people that are eligible already for Medicaid. They just haven't signed up for Medicaid. And if they ever had a major medical event, they would have signed up for Medicaid. For whatever reason, they haven't. They're hard to reach people. Their situation is such that they don't interact with the medical system as much as others, et cetera. So, and then there's an awful lot, as we can see from the current push, of young, healthy people who are uninsured. And so the question is, what kind of contortions do we need to go through to get them signed up for insurance coverage? So the number of people that were really in the sympathetic group of low-income people, moderate-income people, people with a health problem in insecure or inadequate coverage was, as Mark mentioned, millions and millions of people, but relative to the size of the U.S. population, far less than 1/6 of the country. And the question is what to do about that. Another observation I would make is that when you might recall, a lot of this was contended in the 2008 campaign, where the president had an approach to covering people with insurance, and his opponent had an approach to covering people with insurance, which I would argue was a universal coverage plan, just as much as what was enacted, probably even more so. And the president, then Senator Obama, eviscerated it with very serious political attacks, spent $100 million attacking that approach to providing insurance coverage, most of which was, in my view, over the top and misleading rhetoric. So, there's a lot of water under this bridge about how to cover people with insurance. And I'd say that it's just not the case that a replacement plan couldn't do better on most of the major metrics of the current law. The proposal from Senators Burr, Coburn, and Hatch, though not perfect, I think embodies at least some of the thinking that could go into a replace plan that would do far better with much less of the baggage associated with the current law in meeting the objectives of covering the people that need to have coverage for insurance, stabilizing the incentives to stay insured, and doing so at a fraction of the cost of the law that passed and a fraction of the disruption and candidly a fraction of the bureaucracy. One of the main one issue that really needs to be put front and center is that the law, it was an opportunity for the folks who wrote the law to write it in a way that they wanted to write it, and it involved a huge amount of transfer of power and authority from various actors in the health system to the federal government. Now, much of that authority has been exercised in a modest way so far, but that doesn't mean it won't be expanded and grown upon and built upon in future years. I fully expect it will, including things that were enacted in the Medicare program that Mark says he supports. Much of that I don't support. And so I think a lot of this is going to remain contentious, unfortunately, going forward, in part because of the way the law was birthed and the nature of the debate going forward. So I don't see any particular optimism around reconciliation around the current law and just accepting it as it is. I think it's going to continue to be something that'll be contested, at least for the next 2 election cycles.
Well, let me start by saying I agree with that. It's not going to settle down anytime soon, and I don't think we're going to know the extent to which it succeeds in the goals that it set out to serve for some time. In terms of the number of uninsured, I agree that it probably isn't 50 million people who are hardcore uninsured. I think it's a very large number, and that they are, I think, survey after survey and study after study, I should say, shows that those people have been badly underserved, that they have suffered greatly financially as well as in their health, and that there was a very serious need there that needed to be filled. In terms of the number of people who remain uninsured, I think a very important provision of the statute that has not been much discussed is a provision which allows hospitals to determine presumptive eligibility for Medicaid. I think there are going to be a lot of people who are not going to be immediately covered by the statute, but they basically have a catastrophic coverage, that if they show up at a hospital with a serious problem, they will immediately go on to Medicaid. Now, that's in states that expand Medicaid, because a large proportion of the uninsured would be eligible for Medicaid. So I think that probably we're overcounting the number of uninsured who were uninsured before, but we're also overcounting the number of uninsured who will be uninsured afterwards. Of course, also people who get sick and are not eligible for Medicaid may very well be eligible for the exchanges. They may qualify for a special enrollment period, but they certainly would be able to sign up at the next open enrollment period. In terms of how well this thing has worked, I agree. It's not gone so well so far, but it was an incredibly complicated law, far more complicated than it probably had to be for all kinds of political reasons. And it is struggling along, and hopefully will at some point get up on its feet. I believe that it will. As far as the administration's efforts to make that happen, I think the problem is, what do you do when you have a Congress that is absolutely dysfunctional, cannot do anything? Then do you say, okay, well, the law says this and goodbye, or do you try to figure out some way to work within the law, maybe even push the boundaries of the law a little bit to make it work? Previous administrations have done that in other circumstances. This administration has done it in this circumstance, and I think that the changes, some of them I disagree with, but I think that the things that the administration has done to try to introduce some flexibility in the law have, by and large probably been for the good. One final thing, and that is there's a lot of rhetoric about how Medicaid is a failure, Medicaid is a terrible problem, people on Medicaid can't get care. It's something I've been looking at recently. It's true that if you're on Medicaid, you have a harder time accessing care than if you're on private insurance. Although, there again, what do you mean by private? Okay, if you're on Medicaid, you have a harder time accessing care than if you have a Cadillac Blue Cross Blue Shield plan through your employer, yes. But it reminds me kind of Mark Pauly's research on individual health insurance, that he at one point said that people say, you know, they do these surveys where you call up 5 insurers and say, I've got such and such a condition, will you insure me? And they say no, and then you say, you know, you can't get health insurance. Well, but people do. They keep working at it until they get health insurance. And the studies that have been done show that people on Medicaid actually do a whole lot better than people who are uninsured on accessing providers. And most of the time, you know, maybe you have to call 2 doctors instead of 1 doctor, but most of the time you can get coverage. And once you get a provider to take care of you, continuity of care is very good. So Medicaid is not a great program. I'd rather not be on Medicaid, but it's a whole lot better than being uninsured. So I'd like to say that to the extent that we end up looking like Medicaid, maybe not that's the worst thing. Yeah.
2 comments. One of my sons is a history professor, and I tease him by saying, Matt, your problem is you don't have a control group. But I do think that history is important here, even to think about things going forward. And one thing, this actually related to some research we're doing, so I'm partly going to raise the question, which is, what was individual insurance coverage like? I was predisposed to agree with John Gable that it's tin coverage because, well, in my group coverage at Penn, our administrative cost is less than 5%, and then I get an enormous tax break, so there's a negative net cost to me of buying the most expensive plan, which I do, but in individual coverage, the loading is much higher, and it makes sense to buy less generous coverage, more catastrophic coverage when you're paying a higher load. Having said all that, though, we've been looking at data on the out-of-pocket payments by the individually insured pre-ACA, and we're not finding large out-of-pocket payments. In fact, it looks like the generosity of coverage as measured by out-of-pocket payments relative to premiums is in the individual market. We've looked so far at California and 36 states with federal exchanges. Looks to be somewhere between bronze and silver. Not quite as good as silver, but better than bronze. So it's still, well, I don't know if bronze is a precious metal, but we're not, at least in those states, it didn't look like tin. The other thing I would say, since I made the remark, I might as well give you Exhibit A. So Exhibit A of the dumbest possible way to do a good thing, in my point of view, is community rating with no pre-existing condition exclusions. I agree that we need to subsidize people who are high risk and low to moderate income, especially if it's no fault of their own, or maybe even if it is. But using excess charges on other insureds while at the same time trying to persuade them to buy the overpriced insurance seems to me to be foolish compared to what was actually done in the first few years of the ACA, financing a high-risk pool with federal general revenue taxes imposed in the least distortive way on the people who can most afford to pay it. I think we're all in this together. As a person who's been relatively lucky in life, I'd like to make a much larger contribution toward those high-risk people than I'm going to be asked to do so under the ACA, and have my princess ballerina granddaughter make a much smaller contribution than she would be asked to do under the ACA if she bought individual insurance. So I just think there's a much better way. Now, of course, the objection is, well, if you allow the subsidy of high-risk people to be an explicit political choice, as happened in some states, the taxpayers or their elected representatives decided they didn't want to spend so much. But that's democracy for you.
Okay. Well, thanks. We have a few minutes for questions. Wait for I assume there's a Microphone coming. Please identify yourself and phrase your statement in the form of a question.
Okay, Joel Coopersmith from Georgetown. I'd like to ask about some of the professional issues that have come up since the Affordable Care Act has come up. There's a lot of discussion about physician burnout, future shortage of physicians, doctors who can afford it retiring over the age of 50, professional doctors, things that are done by doctors now being done by other professionals, and the coming wars about professional qualifications, and a further bureaucratization of medicine, not only due to federal panels and the Affordable Care Act, but the many hospital requirements now, quality, and also the fact that so many doctors will be working for hospitals rather than independent group practices. I think that all of that will be owned by the Affordable Care Act, even though much of it is not caused by it. And I wonder, my question is actually not about necessarily about the details, but what do you think that's going to have on the political framework in the future? Those kind of changes that many people won't like at the same time that the Affordable Care Act is coming on. Some of it caused by the Affordable Care Act are related to it, much of it not.
I guess I would say, number one, yeah, much of it's not. This is probably where we were going in any event. The other thing is, I just really believe, I mean, I hear this all the time, but I really believe it's overstated. I mean, I think doctors have said this forever. And I mean, there are some real changes going on, but you know, it's not like medical schools aren't like law schools. You're not running out of people who want to go there. I think a lot of people still want to be doctors. It's still a very well-paid profession. It's still a profession that is highly respected, that has a lot of flexibility, a lot of discretion. There's probably going to be some shakeout, but I think that it's a profession that has a good future ahead of it. And also I think there's going to be more involvement of professionals other than physicians in patient care. That probably would have happened anyway and should happen. So, I mean, I agree with you, it's a problem, but I think it's probably overstated and that things will go on.
To repeat a little bit what I said, I think both the use of Medicaid and the apparent use of narrow networks in exchange plans isolates the problem of the surge in demand in terms of its impacts on the population in general, and for that matter, in terms of its impacts on the physician population in general. Only those doctors and those non-Medicaid people who share doctors with large Medicaid populations or large narrow network populations are likely to be directly affected. That's not a solution. Some doctors are going to be really miserable, but it does mean that it's not necessarily a problem for everyone. And I do have to say, though, there has been some research that looked at the question of what happened in Medicaid programs when Medicaid expanded. Did it reduce access for the pre-existing set of Medicaid beneficiaries? And the general result was it not appreciably. So what went on? Well, I'm programmed to say perhaps they hired a lot of nurses and especially if not limited by scope of practice laws to expand the productivity of primary care. I put a lot of money on that and a lot of emotion on that, but I think that's likely to be the sensible response of any practice that is faced with a surge in demand. And then I guess the third question is, well, what are you going to do? At least for the people who are formerly uninsured, getting access, and I agree with Tim on this, to something is better than, well, it's not nothing that they got when they were uninsured, but it was nothing with no dignity, and now it's something with some dignity, and I count that as a step forward. And the rest of us may, and those of us who are physicians or who married a doctor's daughter, may just have to face up to the fact that you can't get something for nothing, including improvements in quality and outcomes in healthcare.
Just one observation quickly on this, which is that some of the frustrations that are occurring in the physician community are related, I think, to the provisions of the law. I mean, the law has a ambition to have the federal government get much more involved through the Medicare program and how physicians and hospitals organize and do business. I mean, that's the ambition of it. And so some of the changes that are underway are in anticipation of future changes down the road. Moreover, some of the frustrations that are boiling up now are related to things the federal government did through the Medicare program years ago. Just to take one example, in 1989, a lot of people trace the physician fee schedule to 1997. That actually is not the real history. The real history was it was enacted in 1989 and then updated and rebased in 1997. And what they enacted in 1989, they thought was going to encourage and pay for time spent by a physician in front of a patient. That was the whole point of it. It was to say, well, we want to value the actual time physicians spend in front of a patient, taking care of their needs and addressing their concerns, et cetera, et cetera. The enactment of the Medicare fee schedule in 1989 had exactly the opposite effect over time. And it's just one cautionary tale, an important one, about the long tail of a federal policy decision from many decades ago and how it has big ramifications and very difficult to unwind, and how we're probably about to do 10 more of those in the next 5 years because the law has authorized it.
We have time for probably one extremely short question and one extremely short answer. And I regularly call on you, but I have to ask people who I don't normally see. So raise your hands. Let me see who you are. How about this gentleman back here?
My name is Samar Chatterjee from Safe Foundation. I just have to quickly correct Jim on one of the things you said, even though I agree with most of your statement that this law creates a lot of confusion and should be reconsidered whether the American people who want to be a guinea pig or not, So that decision should be made, in my opinion, in the next election, and so that we don't continue to suffer the economics of this ACA. Just a comment that you mentioned that illegal aliens always don't pay, are not in part of the tax system. That is not true. IRS has a provision for illegal aliens to get not a social security number, but a TIM, whatever, taxpayer identification number, and a lot of illegal aliens do pay into it, hoping some amnesty would come when all that would add up to that. And so
Okay.
IRS
Okay, thanks.
that they
Let's
will not
get
be
a
reported.
question. Let's get a question. Question right here. Yeah, except you have to wait. And just the question, no long startup.
This is directed at Tim, alluding to long-term care coverage, the patients with long-term problems. They will be insured insurance, but the insurance may not pay for their needed care. Is that correct? Because of managed care, government care, recommended care models, and ignore economic cost containment goals? Were you alluding to that?
I'm not sure what you're referring to. I mean, there is high cost sharing under this legislation for people who don't qualify, who have incomes above 200% of poverty.
No, the people who are expensive patients, who are the patients who used to max out of the insurance coverage.
Yeah.
Do they will now guaranteed insurance?
Yes.
But that insurance may be rationed to them. Is
No.
that true?
Well, I mean,
Because of the targets, the cost containment.
oh, I
targets
see what
of
you're
the-
saying. Yeah, no, I mentioned high-cost case management. I mean, insurers are going to try to figure out how to manage their costs, and in some instances, that may mean denying care. It may mean channeling patients in certain directions. That's always been true with insurers, and that will continue. There are, of course, now internal and external appeals that I think are going to mitigate that, but I'm just pointing out that insurers are infinitely creative in trying to avoid risk, and they will figure things out like that.
Yeah, well, I mean, one of the limitations is that now with the so-called medical loss ratio, there's a limitation on how much insurers can put into case management, which is, I think, one of the problems. When you pick a number, you end up having to live with it. Bob Helms just walked out of the room, so let's have one more quick question. John Graham, did you have a question? No. The gentleman in front of you. Okay, quick, Kelly, please.
Jim mentioned something I thought was interesting, in that essentially individual consumers have a choice: purchase coverage or pay a tax. And the coverage we expect might become rather expensive depending on the level of the plan. Would it be possible for an insurance company to offer a substandard plan and tax support in the premium? And somebody could actually go into the individual market, buy a less than excellent product, and part of the tax that they would incur would be paid in their premium.
Yes,
A way to do that.
yes, and I expect to see that. The statute allows insurers to continue to sell accepted benefits, including what's called a fixed dollar indemnity policy, which we used to call a mini-med. Those continue to be sold, and some insurers are pushing them pretty aggressively, and I will not be surprised when some insurer says, and we will pay the penalty. Now, if it's 2.5% of income, probably not, but there might be some accommodation there.
Okay, the second panel is going to be cut short because Bob's still not here. But okay, one more question. Here's a lady right here. Quickly. And if Bob shows up, I'm cutting you off.
And look, it's just for those of us who are approaching 65 and are also concerned about the health of the government budget. You've both talked about Medicare or alluded to it. Could you give us just a really quick comment on the impact of the law, the most important aspects, and what you're so afraid of?
I guess I'm the senior person here, so there may be, in addition to free rides on the bus, I might as well take the privilege of it. The main, there are a lot of features, but I mean the main motivating factor behind the Medicare part is to cut the rate of growth of Medicare spending. Period, to paraphrase the president. The main vehicle for that, there are two main vehicles for it. One is just to pay less on a fee-for-service basis, particularly to hospitals, because doctors have managed to lobby for reversal, but the hospitals are going to be paid a lot less. And then the other vehicle is this ACO model, where, at least in my vision of it, and how Jim has his own views too, which I more or less agree with, the main thing is it's kind of a Medicare managed care plan favored by Democrats rather than Republicans that is going to be faced with a capitation payment tailored to the federal budget, where the government is saying to that plan, for the elderly people that belong to your plan, here's how much money you can have next year, do the best you can. And I guess that's why I'm worried if I get into that plan. And there's also some features where, if I'm not careful, I could be in the plan without knowing it. But
We're done. Thanks very much. Please join me in thanking the panel.
Okay, could I have your attention, please? We'd like to get started. Welcome to the second session here. The design of this two-session meeting today was to have the first panel discuss sort of the existing situation with the Affordable Care Act, and for this panel to look at the future. You've already heard a good bit of discussion about the future and so on, but this panel is designed to go into some specific areas of the healthcare system, states, and the employment sector. We've got some very well qualified people to discuss this. I'm not going to go over all of their credentials and so on. You have those in front of you, with one exception. I wanted to mention that Alan Weil has now been selected as the new editor of Health Affairs, which he will start in June, right? June the 1st, we hope. Anyway, let me just say this briefly. There's a sort of a common statement about there, that nobody can predict the future. Well, I think what people really mean by that statement is that nobody can be assured that the prediction is actually going to occur. But I've always said predicting the future is easy. People do it all the time. The tough part is for you and me to decide which of these many predictions we want to believe. Now, there are ways that people go about talking about the future. Some people just casual remarks, but other people use lots of data, sophisticated actuarial or econometric models, and so on. But in all of these cases, I think it's important for whoever is talking about what's going to happen in this case, that they come with a sort of sense of history, that they're aware that lots of predictions in the past haven't worked out as people thought. So the important thing, I think, for you in terms of thinking about what's going to happen in these sectors is sort of what's the probability of these unexpected things that might affect these predictions. So I know that's sort of abstract, but I wanted to say it. Now, we have decided to go in the order listed. So, Jeff, we'll start with you.
All right, Robert, thank you very much. There it is. Good morning, everyone. It's great to be here. I don't get to Washington very much. And I'm here on this panel as a representative of the group that has benefited the most from the health reform process so much, which is the healthcare consulting community. The people that build all that defective exchange infrastructure, consultants, the people that are advising, as Mercer does, employers about how to do consultants, the people that are helping hospitals build ACOs, sort of a Naugahyde version of managed care. Those are consultants. So this has been the golden age for our industry, and we're really delighted to be here to talk to you. If you spend your entire career in Washington, you'd think that, Medicare policy, you're sort of running the health system. I think that's an illusion. Medicare represents maybe 22% of total health spending in the country. At max, at full funding, the Affordable Care Act will be putting about $250 billion a year into a healthcare system that by the time we get to 2023 will probably be $5 trillion in scale, maybe 5% of the total thing. So, from a standpoint of just the sheer scale of the enterprise, I think people who work here in Washington don't realize we're dealing with something that is the size of a nation. Our healthcare system is bigger than France. It's bigger than Russia. I am confident that we will beat Germany to $4 trillion. 16 million people work in it. 7 out of the 10 smartest kids in your high school graduating class work in our healthcare system somewhere. So when people in Washington bravely talk about reforming the healthcare system, degrees of difficulty, orders of magnitude, this is way harder than Iraq. It's like invading a country the size of Germany. And I think that's a little bit what's happening now. The main feature of this health economy for most of the last 5 years has been disinflation. frankly something no one, including us futurists, predicted. In 2009, our health system arrived at a rate of increase in health spending that we haven't seen in this country since Dwight Eisenhower was President of the United States, 5 years before Medicare. And we've stayed at that level of maybe 3.8, 3.9% increase in spending for 5 long years. The economists who believe that this was a product of the recession will have trouble explaining why per capita Medicare spending has trended down towards zero during the same period of time, where 85% of the beneficiary population is protected from costs by supplemental insurance or Medicaid or employer coverage, and why Medicaid spending has trended down towards zero, where the people have essentially free care. So clearly something larger is going on than merely a macroeconomic response to a slowdown in our economy. I think the two big things that have brought this aircraft carrier-sized enterprise to a slow glide, Mark Pauly actually alluded to one of them, which was that this industry doesn't have a lot of new products to sell the public. If you look at the hospital of 2013, technologically, it's pretty much identical to the hospital of 1998. Device innovation, new technologies for ambulatory surgery. There really aren't a lot of new technologies in the hospital sector. And this recent reacceleration of cost, I think a lot of people really point to the fact that we've effectively cured Hep C. I mean, only in healthcare is that somehow bad news, okay, or something to really worry about, that we've effectively cured hepatitis C, arguably our third most significant chronic disease risk after diabetes and Alzheimer's disease. But you know, when you look at the deflection points in spending for the various sectors in our health system, they go back in some cases as far as 15 years. Pharmaceutical spending bent downward in 1998. Imaging spending, the $200 billion business that was growing at 15% a year, bent downward and almost came to a halt starting in 2006. Hospital outpatient volume trended downward starting in 1995 and was only growing at about 1% a year by 2010 or 2011. Hospital inpatient utilization trended downward 11 years ago in 2003. And if you follow the industry, I mean, I hear all this stuff about the reacceleration of cost and hospital cost. According to my friends at Citigroup, hospitals lost about 4% of their admissions last year. And there are some investor-owned firms that lost more than 11% of their admissions in a single year. And finally, physician visits bent downward in 2005 and have since fallen about 12%. According to IMS Health, maybe a couple 3% growth in physician visits in the last 6 months. But I think the other factor that has contributed to the slowdown in cost, in addition to the fact that there just aren't a lot of new products, is the question of affordability. You think about this, add up these numbers, 48 million plus or minus until this last January uninsured. Maybe 30 to 40 million more people who, while they are nominally insured, don't have any cash. So they don't really have the money to pay the co-payments that are required by the high deductible plans. So they try to avoid using the healthcare system, as Mark alluded to. And then when they do use it, they don't pay their bills. And then 53 million people on Medicaid. You add up those three numbers, it's half the country. Half the country cannot afford to use our health system without massive public subsidy. It's not bullish, short or long term, for any industry if half the nation's citizens can't afford to use its product. And that issue of affordability really hasn't gone away at all. We're going to give people access to health care, but for the significant number of people that get it through private exchanges, they're facing a deductible fence of anywhere from $2,500 to $5,000. As I heard Paul Mango of McKinsey talk yesterday about some of this, every penny of that $5,000 is going to have to be paid before there's a single dollar of insurance coverage for that emergency room visit or that hospitalization. So very significant barriers to an increase in demand for care exist even with the advent of this new this new coverage. The hospital industry is the largest single piece of our healthcare system's infrastructure, roughly $900 billion industry. And the most interesting thing going on in this space is two things. There's a wave of merger and acquisition activity. In fact, after us, healthcare consultants, the most fortunate beneficiaries of this new regime have been the investment bankers and deal makers that are out there brokering a lot of mergers and creation of larger healthcare enterprises. The theory of these mergers is that they will have market power that will enable them to extract rent from the health insurers in their communities and get higher rates from health plans. And yet, a wave of layoffs has hit our hospital industry, and the pattern of those layoffs is absolutely fascinating because it is the market-leading institutions that allegedly had achieved that mass and scale and therefore bargaining leverage with health plans that are laying people off. The list is really impressive. Vanderbilt University in Nashville, the Cleveland Clinic, the closest thing we have to a machine in healthcare delivery, offered buyouts to 3,000 of its workers and over 300 of its physician staff. Indiana University Health and St. Vincent Medical Center in Indianapolis, the two dominant players in their health system, 1,000-person layoffs. Wake Forest Baptist University Hospital in North Carolina just announced what's going to end up being about 1,000-person layoff. It's a very long list. Baptist in Jacksonville, Maine Health in Portland, Maine, Inova and the Washington Hospital Center here in Washington, the two largest and most dominant actors. Evanston North Shore in Chicago. All of these folks are laying off people. And when you talk to their CEOs, what they're seeing isn't double-digit revenue growth. It's like 3, 4, 5% revenue growth. Their spending is growing faster. And so they're trying to adjust to this uncertainty. And that's what I think this law has principally brought to the health system, this massive cloud of confusion and this threat that the world is going to change. They're responding to that uncertainty by trying to reduce the momentum in their own spending and lay off workers. So, someone alluded in the question period of the first panel to the physician sector. I've spent most of the last 3 years studying the physician business and the future of medical practice in the country. And I don't think there's any question but that a hidden effect, not only of the law, but of the regulatory regime that preceded the law, is to drive the independent medical practitioner out of business and into the hands of corporate owners. The principal movement in this space has been into hospital employment, which has grown by roughly 50% in the last decade. It's actually, the numbers that you've seen in the journals are probably wrong. Maybe 120,000 of the 700,000 practicing physicians in the country, if you don't count the interns and residents that have sort of been there all along, are now hospital employees. And I think and the economics of that employment are really interesting. If you believe the Medical Group Management Association that represents most of those hospital-sponsored groups, the average hospital-employed doc is losing the hospital about $206,000 a year. That is the difference between what they collect in fees for their services and what they pay out in salary and what they spend to support their practices. Why are hospitals doing this? Well, it's because they are able thereby to redirect all of their diagnostic activity, the laboratory work, the radiology, particularly the high-tech imaging like MR and CT scans, as well as the ambulatory surgery, from much lower cost freestanding institutions to the hospital, which may charge anywhere from 3 to 5 times as much as the organizations that are losing the patronage of those employed docs. So if there is an underlying driving force pushing costs up, in addition to curing Hep C, I believe that movement of docs into salaried employment is certainly one of them. And of course, that is being supported by Medicare policy that enables hospitals to charge a technical fee for a physician visit in addition to the professional fee that physician would have gotten in office practice. So from a policy standpoint, I think we're making a mistake. We're sort of lighting a fire under our toes here by giving hospitals an incentive to employ docs and making the implication that that physician services are worth more in a hospital setting than they are in private practice. As for the institutional analysts that follow our business are really kind of conflicted about the impact of this law on the healthcare system. For example, my friend Gary Taylor at Citigroup believes that the Affordable Care Act will be accretive to earnings for the publicly traded care systems, the hospital systems, the physician groups, et cetera, because of the large number of folks that are presumably now going to be able to afford to use their care. And in the cases of some of these institutions, like Tenet Healthcare, for example, a $100 million a year income gain as a result of the Affordable Care Act, I'm not so sure. I think the combination of the deductible fence, the fact that there is a very significant break for that 12 to 15 million people that will ultimately have exchange coverage, the fact that they're going to be facing anywhere from $2,500 to $5,000 or perhaps even more in front-end costs before they get a dime's worth of benefit, I think is going to dampen demand. And I think the people that are really going to benefit the most from this coverage are going to be the safety net institutions that were taking care of a lot of uninsured people before and writing off these huge hospital bills when people come sailing in through the emergency room and crash. Those costs are going to get covered. But the front-end costs, the costs of the care that I think a lot of us believe could prevent the people from crashing in the first place, that isn't going to be covered. And perhaps Bob Leszewski can comment on this later. The percentage of people with a $5,000 deductible that actually use up the deductible in a year is 3 to 4% of the total population. It's a very small number that spend enough to get to the point where they're actually into the benefit itself. So, I guess I'm a little bit less bullish than some of my investment analyst friends. I think right now, certainly in 2014, the Affordable Care Act has been cash flow negative for the hospital industry because they gave up updates. They then took a huge hit from the sequester. I think it will probably be 2016 or maybe 2017 before we reach that kind of crossover where the additional demand created by the Affordable Care Act actually generates revenues to compensate for the front-end payment that they made to cover the cost of this act, which began in 2011. With the physicians, it's a harder thing to say. Again, I think the thing that we really haven't been able to get our hands on is the breadth of the networks that are covered by the exchange plans. How many physicians are actually covered? It's just still pretty much a mystery. Those networks were thrown together in great haste. In many cases, physicians are alleged to be covered by the plans that aren't actually covered. There's no contractual relations. So I think there's going to be a very interesting period of shaking out when people actually begin using the benefits and whether they're actually able to get access to physician practices or not, I think is going to be another question. There is no question in my mind that the industry's bad debts for the big bills are going to go down as a result of this act. That is a good thing. But if you talk to hospital and medical group finance people, what they will tell you is that the majority of their bad debt growth during the last 5 years hasn't been from people without health insurance. It's been from people with health insurance that don't pay the patient portion of the bill. That number is probably going to continue to increase. So, when you think about the three groups of people that we talked about earlier, the uninsured, the 48 million uninsured, the 35 to 40 million that have insurance but don't have any cash, and then the 53 million on Medicaid. In macro terms, what this law really does is move maybe 25 million people from the first group into one or the other of the second or third groups. So I have trouble believing that this act is going to generate the increase in demand for services that most people have been expecting. Now, of course, we saw in Massachusetts, there were a lot of people flooding into emergency rooms. There's been a good deal of emphasis on the fact that newly covered Medicaid folks see a significant spike in emergency room demand. But if you work in a hospital, the biggest battlefield right now is over the decision to admit the patient from the emergency room to the hospital, where there has been very significant regulatory complication in the last 2 to 3 years and the creation of this kind of limbo called observation status. It's sort of like purgatory. You know, you kind of move into it, no one really wants to take care of you, it isn't really acute care, but both private insurers and the Medicare program have been increasingly stringent about whether or not to define a person's illness as sufficiently acute that it justifies admission to the hospital as a medically necessary event. I think we're going to see that, and 70% of the Medicare population now comes in through the emergency room rather than being admitted by a private physician or as a result of his actions. So it's far from clear how much volume or demand growth we're going to see as a result of this law.
Thank you, Jeff. We will now go to Tracy Watts. Thank you.
Thank you. Let's see. It's on. Thank you. So I appreciate being here. I always enjoy being invited to share our survey data in these settings. I'm from Mercer. My name's Tracy Watts, and I lead our efforts around healthcare reform. And I partner very closely with our research department from time to time to gather information on either what employers are doing, have already done, or are thinking about doing. And so what I'm going to do today is share with you some of our survey data that we collected the end of January into February of this year. And the timing was so that we could find out what happened in open enrollment. This is the 7th survey that we've done specifically focused on healthcare reform. You're probably the most familiar with our large survey that we do of about 3,000 employers across the U.S. every year on just general healthcare benefit practices, but this is a special survey on healthcare reform. We had 723 employers participate, and as you can see on the screen, a nice cross-section by size. The survey was open only for a couple of weeks, and so that's why the number is not quite as large as the 3,000 that participate in our large survey. And so the big issue for employers going into 2014 was what impact the individual mandate would have on their enrollment. Currently, employers have about a 15% opt-out rate. So they offer benefits to their employees, but some people decline coverage, either because they have coverage elsewhere, maybe some go without. We think most of them have coverage elsewhere. And so we wanted to see what the impact was of the individual mandate. It was a big question mark for employers in terms of how to budget for what percentage of that 15% who currently have been opting out might come back into the program in 2014. And as you can imagine, the more people that come back in, the bigger impact that has on their overall budget for healthcare benefits. And what we found in our survey was that the enrollment was the impact on enrollment was practically zero. We asked a lot of questions around the eligible population and then who took benefits as a percentage of the eligible population. And we've got 3 years worth of data in here, and as you can see, it barely increased in 2014 and not a huge increase projected for 2015. Now, one of the questions around that is, well, maybe they were already offering benefits to everybody that they needed to begin with. And so the next thing that we asked about were the 3 really big provisions of shared responsibility to employers. We asked, how many of you are providing coverage to everybody that works 30 hours or more today? And so as you can see from the first graphic, 58% already extend eligibility under that criteria. 10% went ahead and expanded their eligibility in 2014 to get to that point, and then you'll see we've got another 31% that will do that going forward. So that's probably the most challenging aspect of the law for a smaller group of employers, but again, it's the biggest challenge. When you get into the minimum value plan and the affordable contributions, you can see from the survey data, over 80% of employers who offer benefits easily meet those criteria. It was not a problem. In the affordable contribution category, those who did not currently have a plan with an affordable contribution for individual coverage, many of them added a lower option plan so that they could, easily meet that affordable contribution requirement. So that was one of our big questions going into 2014. What's the situation, and how are employers dealing with that? We do have just a little bit of industry data on who's the most affected by the 30-hour work week. One of the things that I think is kind of interesting is that everybody just assumes that it's retail and hospitality. And I'll tell you from the cases that I deal with, it's a huge issue across other sectors as well. In higher ed, we have the issue with adjunct professors and students, graduate students who work there at the university. We have issues with per diem nurses that work in healthcare. So, this is not just a retail hospitality issue, but nonetheless sharing with you the data by industry on those most affected. Another thing that I just thought would be interesting to this group when I looked at the agenda and the other speakers today would be what employers perceive happened with the enrollment of those not currently enrolled in their plans. And so we asked whether or not they believed some portion of their employees had either enrolled in the public exchange or gone to Medicaid. And as you can see, 25% thought that they had employees that had formerly waived coverage that actually came into their plan as a result of the individual mandate. 9% said that they think that some of their employees actually went to Medicaid or the public exchange. Now, I wouldn't say that this is scientific data because this is their perception. We don't have, solid data on that. But given the fact that they provide access to care to most of their employees, we thought that, this would be interesting. We asked questions about the average value of the plans because we wanted to know, now that the 60% plan is sort of the new benchmark for employers. In fact, I would say that prior to this law being passed, most employers did not know the actuarial value of their medical plans. That's only a recent phenomenon as a result of the Affordable Care Act. So we wanted to just gather some information on, okay, well, what is the average value of your medical plan? And so as you can see on the illustration, when only one plan is offered, it's reported that the average value is 79%. When two or more plans are offered, the average value of the lowest cost plan is around 77%. The average value of the highest cost plan is around 83%. So a couple of ahas here. First of all, the average value when only one plan is provided, I would suspect if we had historical data on this, that's been a slight decline every year. Because we have seen deductibles and out-of-pocket maximums increase each year, even before the Affordable Care Act was passed. But the aha to me was how tight the difference is between the average value of the lowest cost plan and the highest cost plan, because I thought that the lower cost value would be lower than 77%. I think that that's yet to come. And so the other thing that we looked at was how many for that lowest cost plan have a plan that's really close to that 60% plan value. And only 11% of the 700 that participated in this survey said that they have a plan with a plan value that's less than 65%. So that's pretty low. Nobody's really working the low end of the range for plan value. I think that we'll see some movement there, but this is a good benchmark. This is kind of the starting out point, if you will. Ever since the law was passed, we've been asking employers about their greatest areas of concern. And from the first survey that we did back in 2010, the excise tax in 2018 was the #1 issue for employers. And it actually has continued to be the #1 issue for employers until this survey in January, where the increased administrative burden outpaced the excise tax on the high-cost plans. And I think that we're just at a point with all of the requirements. It's not just the plan design changes that employers have had to make that have been costly, but it's, figuring out and filing and paying the PCOR mandatory fee, and now we have the temporary reinsurance fee, and plus we have the communication requirements on top of that, the summaries of coverage, and now the exchange notices that we had to do in the fall around open enrollment time. So, and now we're getting into how are we going to measure our hourly employees for the 30-hour requirement and reporting and disclosure requirements. And so I think that we finally got employers to the point where they're saying enough. And so as a result, increased administrative burden is at the top of the list. The other things, higher enrollment in plans or higher costs due to the plans, I mean, those are things that we have seen since the beginning and continue to be an issue for employers. I want to just spend a couple of minutes on the excise tax because, as I mentioned, it has been the #1 issue from employers since the very beginning. An interesting finding from a survey that we did last summer, we had about 900 employers that participated in that survey. A third of them told us, last summer, that they were already making changes to their benefit plans for 2014 in anticipation of the excise tax in 2018. So they know, they've done the projection, they know, and they're planning for it. And the thing that's interesting to me, we had the pleasure yesterday of meeting with economists and lawyers at both Labor and Treasury to share survey data and have a discussion around the data. And everybody seems to think that not that many employers are going to hit the excise tax. And it even seemed to be a little bit of a theme in the panel, the prior panelists. And when we take our survey data and we project it out to 2018, about half of the employers that participate in our 3,000 employer survey have a plan, their highest cost plan is going to hit the threshold in 2018. Now, I will say it assumes that they don't make any changes to the current plan, and that is not a true assumption. We know that they will make changes. It assumes a trend around 6%. That might be a little high for some, but for some it's not too high. And so, I think that this is a real issue, and employers are taking action. And the very first thing that they did was to decouple their dental plan from their medical plan if they had those packaged together. The next thing that's been the most popular strategy is to implement a consumer-directed health plan, an account-based plan, whether it's HRA-based or HSA-based. From our survey, we know that they cost on average about 20% less than a PPO plan. And so even if you only get a portion of your population to enroll in that plan, you're bringing costs down. So consumer-directed plans have been a very significant part of that strategy. The thing that I think is interesting when you look at this graphic is that the new focus in terms of greater employer attention is adding or improving wellness programs. And as I listened to your remarks about the decline in demand, all that kept going through my head was maybe we're getting healthier, and we're trying to. I don't think that the data suggests that we're getting healthier, unfortunately, but there is a very strong employer commitment to wellness and to helping improve the overall health of their population. And I would even go back to in 2008 when we really saw a huge recession and financial impact on what employers were able to do with their benefit plans, and there was still a very strong commitment to wellness programs. And so just to put that out there as something that is very much core to the framework of employer-sponsored coverage today. The last thing I want to comment on this slide is the use of private health exchanges. And I'm not going to spend a lot of time talking about this, but you'll see that 2% of those who participated in our survey said that they were offering coverage through a private health exchange in order to help bring their costs down in anticipation of the excise tax. We Mercer, launched a private health care exchange in January. We had 35 employers that signed up for it, and they ranged in size from a couple of hundred employees to 30,000 employees. But one of the things that I want to share with you, just in terms of the ability of the private exchange to do that, everybody always assumes that for a private exchange that it's a defined contribution model. So it's the employer saying, here's a bucket of money, $5,000. Here's the exchange. Go spend the money on your health care. Kind of peace be with you. And when you think about it that way, you automatically kind of get to the conclusion that they probably can't buy as much on the private exchange as what they were previously getting. And we did a bunch of things with the design of ours to try to prevent that from happening. But one of the things that needs to happen and that makes this work successfully is giving people a easy to understand decision support tool so that they make a smart decision about the plan that they buy. Most people who have employer-sponsored coverage today are overinsured, and they buy the richest plan, the most expensive plan, because they're scared that something's going to happen to their health, and they want to be sure that they have access to the very best health care. And so we rely heavily on a decision support tool. And so I just want to share a couple of factoids with you that I think you'll find interesting. So for these 30 employers, we did a summary of the enrollment results of, what did people have prior to going into our private exchange, and then what did they sign up for. And I will tell you, when you log on to our exchange platform, you are immediately asked 5 questions to answer, and they're very basic questions about your economic value and your health situation, so that it can help guide you as you go through the enrollment process. So the average value of plans that people were involved in prior to enrolling was 80%. Once they went through the enrollment process, the average value of the plan that they enrolled in was 71.9%. And the difference in, the financial impact of that was an $800 per employee savings as a result of right-sizing the benefits to better address what that person's need was for purchasing health care. And so I just put that out there as an example. I'm sure that we'll see a lot more data on how these are working, but I think that initially, that's a really good story to tell and to think about. The last thing I want to talk about are the wellness incentives. So a really nice thing for employers that happened through the ACA provisions was the expansion of wellness incentives from 20% to 30%. And so we asked questions in the January survey in terms of whether or not employers had expanded the use of incentives for their wellness programs. And I'll also add, as you know, in addition to the expansion from the 20% to 30%, it could be up to 50% for incentives around non-tobacco use. And so we wanted to know, was anybody using the full 50%, for non-tobacco use? And only 2% said that they were. But you'll see from the data on here that there was a increase in the incentive around tobacco use, 8% for all respondents, 14% in those that were larger employers, and really strong interest in increasing rewards and penalties around wellness. You'll see, over a third for both all respondents and the larger employers to be able to take advantage of that. And back to the point that it's such a core part of their programs. I want to just wrap up with data from a totally different survey. Our administration business does a survey called What's Working. It's a workplace survey, and they survey actual employees. And I will start off by saying that the employees that get surveyed do have access to benefits. They have access to a medical plan, and they have access to a 401k plan. So it's not representative of every person that is employed in the U.S. But we ask a question about whether or not getting health benefits through work is just as important as getting a salary. And what I'm sharing with you on this slide is the percent of employees who agree or strongly or somewhat agree with that statement, that getting benefits through work is just as important to me as getting a salary. And what I think is interesting about these data is that we saw an increase from 90% saying that in 2012 to 93% saying that in 2013. And this is at a time when employers are making pretty dramatic changes to their health care benefits, big movements to consumer-directed health plans, big increases in deductibles, incentives to do things in order to even be able to enroll in your health care benefit plans are tied to what your contributions are. And so I think that it just underscores how important health care benefits are in the employment equation that employers have with their employees, and that it will continue to drive keen employee interest in being able to provide benefits for their employees.
Hey, thank you very much. Let's now take a look at the states with Alan Weil. Alan?
Got to turn it on. It's on the side.
There we go. Okay. I'm going to offer some perspective on where the states are in implementing the Affordable Care Act, and mostly do it through a series of maps that will be hard to read, but are designed primarily to give you an impression, and then we can go deeper if you want, and cover sort of three topics in trying to capture the state of implementation at the state level. Beginning with the story that is almost certainly the most familiar and definitely the most reported, which has to do with the coverage elements of the law. This is a map my organization prepared, but you've seen others about the state choices around building the health insurance exchange, half the states deferring entirely to the federal government, the other half, many building their own, some doing so in partnership with the federal government, some brokering a little deal. But the division of the country between those states that have taken this on and those that have not is well reported. And this is a map. This one comes from the advisory board company. They update it regularly about state choices on the Medicaid expansion, not required due to the Supreme Court's decision. And again, we see half the states now, we've just passed the halfway mark in states that have decided to go ahead with the expansion in the law, and the other half choosing not to do so. In shorthand, I often hear people talk about the states that embrace the law and the states that don't. And I think at this point in implementation, it might be a little more accurate when it comes to the coverage provisions to think of 4 categories of states rather than 2. So I'll begin with the happy embracers. These are the states that said they want to do the coverage provisions, and they're basically fairly happy with having made that decision and view that things are going well. But we do now have a second category that was not anticipated a few months ago, which is what I'll call the uncomfortable embracers. These are the states that said they want to do it and found, particularly when it comes to the insurance exchange, that this was a little more complicated than they thought. And they are now looking at the mistakes they made and trying to figure out what their path forward is. I should point out, though, that despite the lack of comfort, in none of those states do I see a wholesale interest in stepping away from the coverage elements of the law. It's more trying to understand how to deal with the operational challenges. A third category of states is what I would call the happy rejectors. These are the states that had no interest in the Medicaid expansion or building an insurance exchange, and that's fairly settled policy within the state. There's relatively little controversy in some states about that set of choices. But we do also have a fourth category, which I would call the uncomfortable rejectors, which is states that, due to a variety of circumstances over the past couple of years, made certain decisions but are not sure that that's the long-term path they want to be on. Particularly, you could show an evolving slide of the Medicaid expansion choice, and each month we get another state or two that is in the no column starting to have a discussion about what might it take to get into the yes column, what negotiations do they want to have with the federal government about terms that would make a Medicaid expansion more appealing to them. In many instances, you have disagreement between the governor and the legislative leadership about whether or not to move forward. And so in some states, the discussion is quite quiet, but there is a category of states that have not done the expansion elements, but I would not consider that to be settled. So this is sort of the standard what's happening at the state level, exchanges, Medicaid, and I don't actually think there's a lot more to say, and you've probably heard it before. What I want to do is spend more time in the second and third elements and show you some maps that you are less likely to have seen, although if you've bounced around our website, you have, but I'm not going to assume that everyone in the room has done so. So let's start with sort of the garden variety state efforts to build patient-centered medical homes. This is a map we keep, and all the states in the 2 shades of yellow-orange are doing something around the financing models, some that are more mature than others, to encourage primary care practices to expand their purview, to improve their infrastructure so that they are able to meet the tenets of the patient-centered medical home. This is activity that began about a decade ago and has accelerated and spread throughout the country. In the Affordable Care Act, there are many, but this focuses on two initiatives designed to build out the primary care infrastructure beyond the patient-centered medical home, which is a one model, but this reflects states, and one of these initiatives has localities. But between the Comprehensive Primary Care Initiative and the Multi-Payer Advanced Primary Care Practice Program, these are two federal initiatives designed to move beyond the core patient-centered medical home into building out primary care capacity to meet more patient needs and to integrate with a larger swath of the healthcare system. I move into Section 2703 of the Affordable Care Act, which is about health homes. This is a section that gave states enhanced federal funding to work with people with chronic conditions, and many of the states led with efforts to work with people with chronic mental health conditions to, again, build out our capacity in the healthcare system, in the healthcare sector, to meet the needs in a more comprehensive way of people with chronic healthcare needs. And the states in the various shades of blue are at various stages in seeking and obtaining enhanced federal funding for that kind of care transformation. And of course, there's a lot of discussion about Medicare's use of accountable care models. We keep a map of states that are working on their own versions of accountable care organizations. So taking the Medicare design and trying to figure out how might it apply to a Medicaid population, which in many instances is very different. How would you think about the funding flows within those models for a different population? And we see a large number of states trying to figure out, particularly based on providers, saying we're re-engineering to meet the Medicare design elements of an ACO. If we're going to do that, we'd like to see payment models that match it by other payers, and so they're trying to figure out these kinds of questions. Although somewhat separate from many of these other programs, I do think it's important to remind everyone, if you're interested in where states are focused, that the Affordable Care Act also created a whole new set of models for coordination between for people who are on both Medicare and Medicaid, the so-called dual eligibles. These are the highest cost enrollees in both programs. We have a long history of poor integration between these two large national programs when it comes to people who are served by both. And again, states around the country are figuring out how to realign financing and delivery models for this very complex population. Now, I did not intend, and I know I didn't succeed in explaining all of these initiatives, but what I want to try to do is capture why I think it's important to look at these maps and not just the first two that are the ones that are usually brought up in a discussion about what's going on at the state level. And there are a few things I want to say about this constellation of initiatives. The first, and from my perspective, the most important given the work I do with states on health policy, is that there is a tendency in Washington to think of the Affordable Care Act as sort of the beginning of health policy, or the only thing that's happened in health policy in a really long time. At the state level, the ACA really enters a historical stream of transition and interest in the evolving delivery system and evolving delivery models, evolving models of accountability, evolving models of payment. And the view I hear from state officials around the country is that the ACA offered them a whole bunch of tools. Some of them they like, some of them they don't like, some of them in some states they like more than in other states. Some of them are tools that are shaped like a hammer when they need a claw, but it is still it's a toolbox, and they are state by state trying to figure out how these tools fit into a stream of health policy evolution that long predates the ACA and will continue after Mark is successful in getting the ACA treated as just a bureaucratic morass and no one's paying attention to it anymore. The second reason for the second reason for showing you all of these maps is to note that the party divisions that are so apparent on the coverage provisions are largely absent, or at least significantly less apparent when it comes to these delivery system models. That the polarization around the ACA is felt in all areas, but is a lot easier to overcome when you're talking about trying to make the healthcare system more efficient. When the payers, the businesses in your state are saying we can't afford the healthcare system we have, we need to be a part of re-engineering it to one that delivers us better results and is more affordable and higher quality, and these are tools we want to use to do so. That's a very different conversation than whether you are doing Obamacare or you love or hate the law. And so the party divisions are much less apparent in these delivery system oriented programs than they are in the coverage. And the final thing, the final observation I want to make is that most of these are actually a whole lot harder than coverage because they involve the complexities of care, organization, delivery, and finance, which, believe it or not, is a whole lot tougher than figuring out whether or not someone should get a card and getting it to them at the right place at the right time, although we've learned that that can sometimes be hard as well. But this is a multi-year, more like multi-decade endeavor. These are tools and pieces, but they are what you have to understand and the sector you have to work with and the interests you have to work with are actually far more complex, and therefore federal support for these initiatives and state efforts to do these kinds of things has a very different timeline and trajectory than the timeline of bringing up an exchange or bringing up a Medicaid expansion. So these are slides and maps that most of America hasn't seen, and most of the policy debate around the law tends to forget even exist. But again, they demonstrate, I think, that state health policy has been active long before the ACA, that these kinds of activities don't necessarily divide along the same partisan dimensions as much of the law, and that they offer a level of, they require work at a level of complexity that many people don't want to take on, and frankly for reporters it's very hard to describe this stuff, which is part of why people don't know about it. Which leads me to the final segment, which is to make sure in any discussion right now about where states are that people are aware of initiative of the Centers for Medicare and Medicaid Innovation called the State Innovation Models Program, which is the federal government's largest investment that I can think of ever in state efforts to improve the organization delivery of care with the goal of achieving the triple aim. And these awards, and again, I won't go into huge detail, but these awards were made a little bit more than a year ago. States were divided into different categories, but basically we have a small number of states that were far enough along in their thinking about where they wanted to go that they were given funds to implement, a larger group of states that were given funds to design the models that they want to use. And for a couple of months now, we have heard that any week now, the federal government will announce a second round of this competition, but we're still waiting for it. So why is it so important that I make sure you're aware of this program? Because of the attributes of what states are trying to do under it, because it has, in my mind, become much more of a catalyst for state thinking about healthcare reform than I would have imagined when it was first released. So one element of these models, of the approaches states are taking, and the states take very different approaches, but one element is multi-payer payment reform. So we hear all the time about how the payment models are broken and fee-for-service encourages fragmentation and overuse, but it's very hard to get those who actually deliver care to change how they think about care delivery if different payers are paying them for different things. And so Medicare is criticized when it doesn't change from its current model, but is also criticized when it changes from its current model because those who are delivering care have difficulty understanding how to respond to these variable signals. And a key feature of the state models is to bring multiple payers together, Medicaid, private payers, but also the ability to bring in Medicare to think differently about payment. The second attribute of these models that is such a critical component of them is efforts to integrate across systems that have built up as silos. So there's a tremendous amount of work right now going on trying to figure out how to integrate mental health into the delivery system that's focused so much around physical health, when we know that the interactions between these are profound and that poor mental health and poor management of mental health conditions is a huge driver of physical health care costs. So there's a lot of work going on at the state level to do this around oral health, around public health and population supports, even efforts to integrate in the social services systems. There's just a tremendous amount of discussion about bringing systems together that is not, to my knowledge, occurring anywhere else. And I think one of the particularly interesting elements of many of these models is their interest in building a community infrastructure to support the health of communities without regard to the insurance coverage that the people in those communities might have. And so while we have a lot of plans and in many instances providers trying to build infrastructure to reduce unnecessary readmissions or help people with their chronic conditions not have those conditions deteriorate, though when you build that infrastructure inside a health plan, whenever someone changes coverage, they lose that support. And increasingly, states are realizing that if they want to achieve longitudinal improvement in population outcomes, they need to take some of that infrastructure and put it in the community where people actually live so that they're able to access it even as other parts of their lives go through transitions. So these are just a few examples of the kinds of things states are trying to do under these models. So let me just close with, as Bob said, the admonition that we look forward. And I want to close by circling back to the first two slides, although I won't show them to you again, which is that I think the most interesting dynamic that I'm observing in the evolution of state implementation of the Affordable Care Act is that we're now starting to see this part of the curve, the delivery system reform efforts, feeding back in to this decisions about the coverage elements, meaning Medicaid and the exchange. And that basically, as states are getting more mature in their thinking about what it takes for multiple payers to come together and demand a higher functioning, more efficient delivery system, some of the important tools that you want to use in sending that signal to the healthcare system are your Medicaid contracting rules and your exchange plan certification rules. And if you don't do a Medicaid expansion and if you leave the exchange to the federal government, you've left those tools on the table. And so the less ideologically fraught elements of the law that have to do with improving delivery, they're very complicated, but they're not as ideological, I believe are beginning to drive re-examination of the coverage elements in those states that are starting to see these tools as critical for delivering better value for their citizens, which is something that is embraced by political leaders of both parties. And so I think over the next few years, what we're going to start to see is that if there is a sense that these models are successful in improving healthcare systems, that is going to lead to a revisiting of some of the state coverage decisions as they realize that in order to achieve these outcomes, they have to have those tools at their disposal.
Okay, thank you very much. We've got a few minutes. I'd like to, I promised to give you a chance to wrap up and so on, but I want to go to the audience and see if we've got some questions. I know you've already asked so I want to go to Jeff.
Just a quick question for Tracy. One strategy that I've heard about that employers might consider is offering what are called bare bones policies, since nobody knows what minimum essential coverage is. So they avoid the $2,000 penalty, but maybe almost worthless, but it's there, but not worry about, but pay the $3,000 penalty. Are you seeing employers thinking about that?
We are aware of some employers who have very large variable hour workforces that have implemented something less than a 60% plan. They go under several names. I think the one that is most commonly used is a skinny medical plan, which tends to be 100% coverage for preventive care, packaged with the hospital indemnity type coverage that was spoken about earlier that kind of replaces the mini-med plan. They are relatively inexpensive, and for somebody that previously had a limited medical plan, attractive. It it insulates them from being subject to the tax for the individual mandate, so it is actually a bonus to the employee if that's something that they want to protect against. And it does meet, the offer of coverage requirement to avoid the initial, the $2,000 penalty. There are also employers that are considering those in addition to a plan that would be a 60% plan and have affordable contributions as a way to offer a more affordable option for somebody that doesn't think that they can afford that minimum 60% plan. If you're using the safe harbor for the affordable contribution, so it's somewhere around $90 a month, for some people, the idea of paying $90 a month for a 60% plan that has, a $3,000 deductible doesn't really seem like a good economic decision for them. But paying less than that for something where you get preventive care, and if you have to be hospitalized, at least you get that daily payment, or however it's designed, maybe is a better financial decision for them. So yes, we are seeing them.
Any idea as to percentage?
Yeah, actually, I do know that. So we asked a question in our survey about offering, we just said offering a plan that's less than 60% minimum value. And so we asked who's doing it and who is considering doing it. And I want to say, I thought I had that piece of paper, that, here we go. 8% are currently offering a plan that has a value of less than 60%, and another 15% said that they are considering doing that. When we offer up a spectrum of strategies for employers to consider, we have sort of a third category that we call alternative strategies, and they are ideas around offering even like a PPO plan, but it's less than 60% plan, perhaps the skinny medical plan, or how do you leverage the accepted benefits.
I'm sorry, the last question was Tim Jones from the first panel, so yes, please. Would you wait for the mic and please identify yourself?
I'm Barbara Dello. I'm a nurse. I'm a caretaker and a parent. And I come here because I find the most thoughtful discussions of healthcare here at AEI. However, I am aware that I'm listening mostly to economists, professors, evil insurance experts, and sometimes even social engineers. I talk to very few people who work with patients directly. How can you assure us, the people who are living with illnesses and who need health care, that you truly will act in the best interest of patients you never even see or know?
I have no idea how to answer that question.
Well, the first answer is I don't think anyone can assure you of that. But the reason I went into more of a focus on what's happening at the state level around the delivery of care is that I think, first of all, it has very significant implications for patients and caregivers. And second of all, the process that states are employing, by and large, to do that kind of work is far more participatory and collaborative, in part because it's not as as challenged by the partisan divides that make it almost impossible to have a conversation about many of the other elements of the law. And in fact, most states, and I don't want to romanticize state government, but I do work with people in it, it's pretty hard to move these agendas without consensus, and it's often quite difficult to achieve consensus unless you have brought a very large a number of people to the table, including patients and caregivers who are not quiet about their concerns and hopes for where the healthcare system is going. And so I view these kinds of discussions that are occurring state and locally about reallocating and redesigning the care delivery system to better meet the needs of patients and to be more affordable to those of us who are paying for it as an opportunity for that engagement. And as I say, I think those engagements are far more genuine than much of the discussion that occurs about the parts that are more politically polarized.
You know, I talk to direct caregivers all the time, physicians, nurses, nurse practitioners, people out in the field, and the overwhelming message that I'm getting from them is that we are absolutely inundating them with paperwork. And that this may be the only industry in the history of American industry that's actually seen a decline in productivity as it's automated. What I hear people saying when I ask a nurse what percentage of your time is actually spent with patients, it's rarely more than a third. And when you ask, well, what are you doing the rest of the time? Well, they're typing. They're checking boxes. They're coping with a flood of documentation that is in the most minimal way connected to actually improving the welfare of the patient. So I think that's one element of this that we really need to attend to. We need to begin reducing that paperwork burden and asking serious questions about how important is it to divert a nurse or a physician's time to answering these questions. I disagree with the people on the first panel. I think there's going to be a very significant shortage of frontline caregivers, and a lot of it we've done to ourselves.
Yeah, I just want to comment from an employer perspective. First of all, many employers have their data, their medical claims and utilization data in a data warehouse where they're actually able to segment out their population to know who is at risk, who's kind of in the middle and just has chronic conditions, and those who are actually healthy. And a lot of effort goes into trying to improve those ratios so that they have more people at the healthy end of their spectrum. Everything that goes on within their healthcare benefits program is aimed at being sure that people who need the care get the right care in the right place at the right time, and those who have health challenges, in particular chronic conditions, are getting tools, resources, health coaches, everything that they need to help them manage their conditions. So that's the first thing that I'll say on behalf of employers. But secondly, I'll say that we've had an effort underway with several of the major insurance companies where we've actually built new care management models within the insurance company that our clients take advantage of. It's called Mercer Health Advantage, where we have a higher ratio of clinicians to patients. And we have already demonstrated much better outcomes as a result of those efforts through that it's called Mercer Health Advantage, that care management program. And so I think that employers are very much dedicated to centers of excellence, to programs that drive health and wellness, to done a lot of medical home pilot projects so that somebody has one place that they go for all of their care. And if they wake up in the middle of the night and something's going on and they think they need to go to the emergency room, they call their medical home and say, I'm having this symptoms, what should I do? And the person either says, go to the emergency room, I'll meet you there with their medical records to help them navigate through that, or they'll say, you know what, do this first and call me back if that doesn't help. And so I think employers have invested a lot in providing better care to their employees.
Okay, we're almost out of time, but John, a quick question, please.
John Graham from National Center for Policy Analysis, and I'm going to risk looking very foolish by misunderstanding the private exchanges. So a question of clarification. Do I understand that we're moving out of the self-insured ERISA benefit, and I'm looking now at a choice of state-regulated policies? Is that what I'm doing in a private exchange, or have I misunderstood that?
Well, in Mercer Marketplace, which is our private exchange, we have a mix of both insured and self-insured products. And of the 30-some-odd employers that signed up for Mercer Marketplace on January 1, all of those that were previously insured in their group programs remained insured, and those that were previously self-insured in their group programs stayed self-insured. And so we have the flexibility to administer Mercer Marketplace with both insured and self-insured plans.
Okay, I've been told that we must end this, and so that means I can't answer all the questions I wanted to ask. So I want to thank our panelists and for all of you for participating, and we're next to have lunch. Yeah, it was 12:15, we'll start the lunch thing, yeah.
Sure.
Charlottesville. I'm just 100 miles away. I used to work in I moved to Virginia in 96 and bought a farm. Right.
We bought it in 07 and the market was down. But then our daughter announced she was going to have twin boys, so we got a grandson.
Oh, so you're not going to move away. I'm grandson 3. My kids are not reproducing for some reason. Good job, Alan. That was very thoughtful.
Very good job. But I like that discussion about my question is going to be sort of CMS.
Well, let me put it to you differently.
There's a lot of complaints about
In some places, you know,
I think that would have, it's too bad we didn't have time for that. Because I mean, I think they're at the high level, they're very supportive, but once you get down to the details, and I probably wouldn't have used that word on the camera, but it's really been
Good afternoon, everyone. I hope you're enjoying your lunch. I think we'll continue on with our program at this point. We have a real treat, and we're very, very grateful that Bob Lashevsky has agreed to come and be our lunch time presenter. Bob is the president of Health Policy and Strategy Associates Incorporated. He's a consultant to the policy community as well as to the marketplace community with great expertise in the insurance industry. He's been doing this for more than 20 years now. And he was named because of his incisive and clear writing about the implementation issues in 2013. He was named by the Washington Post as 2013's Wonk Blog Pundit of the Year, which is actually a pretty fine distinction. He was Chief Operating Officer of a health and group benefits insurer and has been active in and around the health policy and marketplace issues in this field for a very long time. He's a real expert, and we're very, very grateful, Bob, that you're willing to come and talk to us today. Thank you, and join me in thanking Bob for his coming today.
Thank you, Jim. It's great to be here. It's great to be with all of you today. I've been a real fan of Jim and Joe for a long time, and as scholars here at AEI, and I appreciated very much getting their invitation. I'm going to give you my perspective today. It's going to be a different perspective than you've heard, at least from where I come from. Just so all of you know, I work in the marketplace, and I learned long ago that my job was to figure out how to satisfy customers. I have a number of clients out there, and what they expect me to do is to figure out what's going on in the marketplace and what's going on in federal policy and help them navigate their business through that change. If they want the conservative perspective, they'll go to Fox News. If they want the liberal perspective, they'll go to MSNBC. As business people, they need to know what's going to happen and how it's going to impact them. And I'll try to bring that perspective here for you today. I've been working in Washington one way or another, either as an executive or as somebody running his own business for more than 25 years. As an insurance industry executive, it occurred to me a long time ago, way back, that the insurance industry could not sustain itself if its business mission was to figure out who not to cover. In order for the insurance industry to survive economically and politically, it had to figure out how to cover everybody. And I also figured out pretty quickly that as an industry, we couldn't do that ourselves. If as a chief operating officer, I dropped pre-existing conditions tomorrow afternoon, I'd have had a long line down Berkeley Street in Boston of people lined up to sign up for my coverage, and I'd be broke pretty quickly. So I realized there is a role for government as a referee in this whole process. Jay Carney said a few months ago that I had been an opponent of Obamacare for 20 years, which I guess makes me the first opponent for Obamacare since it's only about 5 years old. I don't see myself as an opponent of Obamacare. I'm certainly not an opponent of health insurance reform or of health care reform. And as most of you in this room know, those are two different things. I am a critic of Obamacare, and I think it needs lots of changes. But I guess everybody says that today, so that doesn't make me unique. I'm first going to tell you what I'm going to tell you, and then I'll do my best to tell you. The Affordable Care Act has not cleared the tower, to borrow a headline from one of Washington, D.C.'s media outlets. It needs fixing, particularly in its health plan offerings. Once it passed, and it was clear of the Supreme Court, and it was launched, and President Obama was reelected, there's never been any doubt in my mind that this law will be enacted. I don't think it's going to look that much like it does today 10 years from now or even 5 years from now. But it's also clear to me that we're not going backwards in this country. We're only going forwards. Now, it does need a lot of fixing. One of the things that concerns me about the so-called 8 million enrollment is it might convince the ardent supporters of Obamacare that it doesn't need fixing. There's a whole lot of difference between operating the monopoly in health insurance in the United States today in the small group and individual health insurance market and actually have created something that people like and want to be part of. There's a big difference there and a big distinction, and I think that's the most important thing to understand where we are with the Affordable Care Act today. Now, I'll tell you where I think we need to go, and I'll tell you where I think the fixes need to be, short-term and long-term, but I'll also tell you that I don't think there's any chance we're going to have any fixes before at least 2017. It doesn't really matter what happens in the election in 2014, whether the Republicans capture the Senate or not. We're not going to have the environment or the votes for any kind of substantial change to the Affordable Care Act. We're probably not going to have the political atmosphere for any substantial kind of change. I think this thing just limps along for a number of reasons. It limps along actuarially or financially, and it limps along politically. So I will also tell you that I think while the supporters of Obamacare citing 8 million are pretty cocky these days, I think Republicans are overly confident as well. I actually think the Democrats could take this issue back by November if the Republicans aren't careful. So there are two very different interpretations of the so-called 8 million enrollments. The first is that the enrollment has dramatically exceeded expectations, or we've hardly made a dent in the number of people who are uninsured. Or the enrollment surge proves the program is working, it's on its 3-year projected CBO track, and doesn't need any major fixes, or the program is still a regulatory nightmare, needs to be repealed and replaced. I expect most people are sort of in one camp or the other on this. But I would also suggest there's more commonality than that if we really think about it. Now, we've seen a lot of the surveys, and it's been at the heart of whether Obamacare is in fact succeeding or not. The McKinsey survey came out first. This data was fairly early, February. It doesn't include the late surge in enrollment. And what it pointed out is that most of the people who were signing up were previously insured, that we weren't really attracting the uninsured into the program. Now, these numbers have almost certainly changed in the last 2 months, but I will suggest that the chronic problem this program has is attracting people who were not insured before, fundamentally because the way the products, and in my context, in my background, these are products you sell. The products are not all that attractive to people. The Rand Corporation came up with a survey that went into mid-March, came up with some of the same conclusions, that we were getting more of the people moving over from the insured market than we were picking up uninsured people. And this is a fundamentally important question, because why did we turn the insurance market upside down in the individual and small group market if we're not going to be successful in getting the people we wanted to get in the first place? This is at the core and the heart of whether we can be confident that we're on the right track or not. Now, I will also tell you that when you look at these polls, be careful. This particular poll says that the majority of people who were gaining insurance were gaining it in the employer market. Now, you heard the Mercer representative say a few minutes ago that there didn't seem to be a lot of indication from their surveys that that's happening. I was with one of the largest self-insured insurance companies in the United States yesterday, insures millions of people in the self-insured market, and I went to their head of marketing and I said, are you seeing any increase in the employer market and the number of people signing up? He said, no, nothing, flat. And that's what I continue to hear all over the marketplace. This survey indicates we're signing up all kinds of people in the employer market. I don't know where they are. I'm not saying that my information is better than something the Rand Corporation would put out, but I will tell you we need to be very, very careful when we look at these polls. We need hard data. Now, the most recent poll came from Gallup through April 14th, reflecting more the surge. And the bottom line is that Gallup has found that probably about 1 in 4 people who are uninsured has found insurance either in Medicaid or otherwise. That makes some sense to me, because when I look at the enrollment numbers and when I look at the 8 million people coming through the exchanges, you can make some comparison to hard numbers rather than just do polling. The 8 million needs to be reduced by the people who aren't paying. How many aren't paying? 17% is a pretty good number. As I go around talking to people as recently as yesterday, this particular carrier has hundreds of thousands of people in the exchanges. It's more than 20%. More than 20. It's not as bad as only 15% aren't paying, and it's not 20% either. It's in the middle. And so if you adjust that 8 million by about 17%, which is going to be a pretty good estimate, I think, when it's all said and done, and then you adjust for the fact that 83% of the people are subsidy eligible, you get a number that you can compare to the Kaiser Foundation estimate of 17.2 million are subsidy eligible, and what do you get? Somewhere between 25 and 30% of the subsidy eligible have signed up. Now, if you're inclined to believe in the CBO numbers that we're going to get it 1/3, 1/3, 1/3 over the next 3 years, you could say we're on track. If you're somebody who spent his career in marketing, as I have, and you look at an open enrollment that effectively lasted December, January, February, March, and into April, and 30% of the eligibles signed up and 70% didn't, that tells me you got a problem with the customers that you need to worry about. So I would also, it's also interesting as I talk to insurance agents who are signing people up. The insurance agents are a big part of getting people signed up. And as I talk to people who run call centers in insurance companies who are talking to the customers on the other end of the line, what they're hearing is a lot of complaints about the product, about the offerings. At the heart of the problems I think Obamacare has, and as economists and health policy experts and so forth, you can all have your opinions on these things, and the macroeconomics and the microeconomics. I did a post on my blog not long ago. I recounted a marketing story from the 80s. It was about the dog food. This dog food company went out and created this absolutely fabulous dog food. The scientists got involved. The manufacturing people got involved. They went out and got the best consultants from all over the country, and they created this new dog food, and they went out and sold the dog food. Nobody ate the dog. Nobody bought the dog food. So they had this meeting. They brought the CEO in, and they had the whole team, and they had the expensive consultants, and they're trying to figure out why nobody is buying the dog food. Finally, some intern in the back of the room raises his or her hand and says, Mr. President, it may be that the dogs don't like the dog food. And I think there's a problem here when you've got 30% of the people walking away and 30% of the people signing up, 70 walking away. Remember something important about Obamacare. Obamacare is a monopoly. There's not another place to buy health insurance. If you're a responsible person and want to have health insurance for your family, you could have afforded it anyway, and you want to be that responsible person, there's only one place to buy it. If you're a person with pre-existing conditions and you can finally buy health insurance, there's only one place to buy it. So there's only one place to get this product. And in addition to that, the government will pay a big portion of your cost. So you've got a product here that is a monopoly where somebody's paying a good share, if not all, of the cost for you to buy it. And so you put out a product where you don't have to pay most of the cost, and it's the only place you can buy it, and it's the responsible thing to do to buy it, and 70% passed on buying it. There's a customer issue here. The fundamental problem is that people are still, after the subsidies, expected to pay about 10% of their after-tax income for a plan with pretty high deductibles. As Avalair pointed out, the average silver deductible is $2,600. And a bronze plan is $4,500. And then we've got the narrow networks. And folks, we don't understand the consequences either in the market or anywhere else of these narrow networks so far. There are a number of issues there. Take a look at the way the California individual health insurance market has rearranged itself, where the insurance carriers with narrow networks have taken disproportionate market share, and the carriers with the less narrow networks have lost share. Clearly, people in California voted with their feet toward the narrow networks. Now, if you watch the Covered California situation carefully, you'll know Covered California had a hell of a time with the provider directory. If you went on the exchange to buy a plan, you're going to have an impossible task figuring out who your doctor and hospital was. But they bought narrow networks. Why? Because narrow networks will produce a price 25% cheaper. That's why. And if they don't know who's in the network and it's 25% cheaper, which direction do they move? And the narrow networks are also interesting from another perspective. In the employee benefits market, for years, we've been experimenting, insurance companies and large employers, with high-performance networks. These are narrow networks where the insurance company or the large employer determines who the best provider is. The highest quality providers are very often the lowest cost providers. So you go find the centers of excellence for your heart procedures and so on and so forth, and you contract with them, and you steer your people toward these networks, not because they're cheaper, but because they're lower cost and they're better. That's not what we have here. What we have in these narrow networks, in these exchanges, is literally the insurance company mailing out a contract to all the doctors and hospitals in town with Medicaid reimbursement rates or something like that, with the assurance that if the doctor or hospital signs the contract, they're going to get the exclusive business from that insurance company in the exchange, and then see how many sign it and send it back. That's the selection process. And so this whole business of narrow networks is really going to have to play itself out. And you really have to wonder from a customer satisfaction perspective where we are on this. Comments were made this morning that maybe we will devolve toward a Medicaid-style program. I think there's, well, if the narrow network is basically a Medicaid contract, I think there's a fair risk that can happen. But, and in the context of the conversation, maybe I misread it, was, well, if it happens, it's not so bad because these people didn't have health insurance anyway. Wait a second. The people entering the system who are new didn't have health insurance before, but there were somewhere between 10 and 12 million people in the individual market. They tend to be higher income people, self-employed income people, intelligent, well-educated people. They're running their own little businesses out there. They could afford before to buy health insurance. They thought health insurance was important. They had assets to protect. These people can only buy now from the Affordable Care Act insurance monopoly. Are they going to be happy in these narrow networks? More than that, anybody who thinks this is about the individual market better take another look. The small group market is regulated in exactly the same ways as the individual market is. It has to comply with all the same things, and it's undergoing the same change as the individual market. And what are there, 35 million or so people in the small market? So you take 35 million people in the small market, 10 people in the old individual market. We're in the process of moving something approaching 50 million people in this country into the Obamacare regulated monopoly. And if that starts sliding toward Medicaid-style programs, is it a sustainable political thing to do? So again, I think the core of this is, from my perspective, the issues have a lot to do with the kind of program that we've really created here. Now, the big question I always get is, what will the health plans do? Conservatives were convinced that health plans would go insolvent or back out of the market, and that's just craziness. It's not going to happen. The first thing to understand is there's just little or no data to know what we have today. I mean, I was talking to actuaries yesterday with hundreds of thousands of people in these exchanges. What do you think we are? I don't know. You know, and that's where we're going to be for some time. The first indications, though, are if you're only getting 20 to 30% of the eligible group, this is not sustainable. We have not cleared the tower. If you believe in the CBO projections, and this is on autopilot towards 70%, then you know, take the weekend off. If you're concerned about the level of signups, this thing has got to get to about 70% market acceptance to be sustainable, and it can be sustainable. A comment was made earlier today that you really are going to need high-risk pools anyway, that if you try to bring all these sick people into the marketplace, you can't really rationalize that in an efficient way. You've got to have a subsidy somewhere. Well, you do have to have a subsidy, and that's why the 3 R's reinsurance scheme in Obamacare was created to create a 3-year transition pool. But if you get a good spread of risk, you don't need big subsidies to bring the sick people into the pool. An employer with 1,000 employees and no mandate has a good spread of risk and an efficient cost structure. You don't need You need reinsurance pools in the short run because they're all going to show up on day one really sick. But if you can attract people into the pool, you will rationalize the costs. And every employer out there that stands on its own in self-insurance with no individual mandate proves that. All individual employers also prove you don't need an individual mandate. What you need to do is attract enough people. What Obamacare tries to do is coerce people with lousy products. And that's the fundamental challenge it has towards success. But having said all of that, the rate increases the insurance companies are going to have are going to be fairly moderate going into the next year. I said in my blog the other day, they'll probably be 9.9%. They really will. Why will they be 9.9%? Because if you go 10%, you get scrutinized by the federal government. If you come in under 10, you're not going to get scrutinized. And they don't have any data, and they don't know. But I can tell you that healthcare trend in this small group in the individual market is probably in the double-digit range. It's probably in the 7 or 8% range. Individual trend is higher than the large market because there still is anti-selection in the individual market. Even with Obamacare, you saw it, only 30% showed up. And then there's something called deductible leveraging. And don't ask me what that is. That'll take another hour. But these deductibles are so darn high that it actually boosts the trend rate. So that theoretically, they've probably got to do 12, 13, 14% increases. But since they don't have the data to prove it, and they don't want to make this any worse than it is now, and they've got the protection for 3 years, I expect to see moderate increases. Now, you're going to see some big and little increases here. You know, what you had in this marketplace is some people came in way too high, some people came in way too low. They're going to get pat toward the middle. So you will, anybody who wants the example of somebody with a 45% increase will find it, and anybody who wants an example of somebody who dropped the rates will find it. And anybody who wants an example of an insurance company coming into the exchange will find it. What you've got here is essentially stasis for the next 3 years as people figure out what they've got. And a lot of people say, why are the insurance companies in this market? Why aren't they upset and getting out, yada, yada? You know, Obamacare, the Affordable Care Act, is a monopoly. If you're going to participate in the small group and individual market, and they are effectively the same market, folks, go look at the rules. If you're going to participate in the individual and small group market, not just the individual market, if you're going to participate in this 50 million person market, there isn't an alternative. There isn't plan B. Carriers generally believe this thing is going to evolve, and they're going to be protected by the reinsurance pool for 3 years. They've got time. And one way or another, this will all work its way out, and I believe that too. That doesn't mean we're in great shape. It means we're not stupid. We'll figure a way to manage ourselves out of this. Carriers are a lot more worried about Medicare Advantage payments right now than they are about Obamacare. I mean, the Obamacare is, Aetna did its earnings the other day, Obamacare doesn't even move the needle for a publicly traded company. And the other thing to remember is health insurance plans are getting used to the government being their biggest customer. This is a picture of what the health insurance industry looks like today. Now, when I grew up in this industry, I was in the employee benefits business. I was in the group health insurance business. I couldn't have even imagined. Now the health insurance business is only half of what they do. The other half is manage Medicaid, manage Medicare. The federal employee health benefit program will probably be bigger than Obamacare for the next 3 or 4 years. Medigap, Medicare Supplement, all of these products. So when Obamacare finally gets on this chart in a year, it will probably be the smallest piece of the pie. But it is the monopoly in that part of the market, and they've got to deal with it. What will employers do? I talked to a lot of employers. Yesterday I did a board of directors meeting at Blue Cross. A third of the people were doctors, a third of the people were hospital executives, and a third of the people were employers. It was a great cocktail party, let me tell you. There is a movement toward defined contribution health care, no question about that. Private exchanges, these are all product terms. It comes in various forms, colors, and varieties. One of the observations that I will make about the marketplace over the last 12 months that I think is important is that Obamacare really has changed things. It used to be that your average Blue Cross, your 80-20 standard option Blue Cross plan was the standard health plan in America. That's what we gauged. Everybody had something like that, and that's what we considered good health insurance, and that was the standard. What's starting to happen now is the perspective is starting more to move toward the Affordable Care Act and what's in the exchanges. Today, an employer, instead of saying, do I need the 80-20 Blue Cross standard option, or do I just need to be better than what's in the exchanges? With much higher deductibles and copays, 60% actuarial value. Tracy pointed out that most plans are 70% plus in the employer market. The new standard in employee benefits, you can sort of see this reference point growing out there, is Obamacare. You don't like what I'm giving you? Well, go to the exchanges. Go with I'm giving you a lot better than the government gives you. And people are really worried about the Cadillac tax. Most employers will not hit the Cadillac tax because they're changing their plans now. And when you change, and the changes you've got to make, you can't just shift costs to the worker, because the Cadillac tax aggregates worker and employer cost. You've actually got to cut the benefits. And so so Obamacare actually gives them permission to do that. Anybody who says that Obamacare isn't having a direct impact on the employer market, hasn't spent any time in the employer market in the last year. Are the fees and expenses no more than 2%? You bet, I agree with that. But don't presume it's not having an impact in the employer market. Ask your friends who are employed by Fortune 500 companies what's happened to their benefits the last couple of years and what's happening next year, and you're going to get an earful. There's an entirely different perspective there. And there's a dichotomy starting to grow in the employer market between employers who have to compete for skilled workers and employers who don't have to compete for skilled workers. If I've got a bunch of restaurant workers, I don't need to worry about providing good benefits anymore. You know, it used to be, not that long ago, that the guy who swept the floor in the shop with the broom had exactly the same health insurance as the CEO had. We all had the same health plan. That is changing very quickly. Part of it would have happened anyway. There was clearly a movement going on. I'm not here to blame the Affordable Care Act for all this stuff, but if anybody doesn't think that the Affordable Care Act is part of this mosaic, they're dead wrong. Medicaid expansion, one of my favorite topics. I may be one of the biggest critics of Obamacare, but I'm also one of the biggest critics of Republican governors who don't expand Medicaid. I mean, my view is put up or shut up. For years, I've been hearing Republicans say, give me flexibility, let me run it my way. The Medicaid program is broken. You bet it is. We need to experiment with different things. You bet we do. We need to try market-based principles. Go for it. And the Supreme Court gave the Republican governors a golden opportunity. Now, some of them have taken advantage of that in controversial ways. Arkansas is one of the first ones out of the box. What they've gotten is the ability to put people in private plans. They haven't gotten flexibility in plan design, but they got flexibility in moving into managed care. That is not an insignificant concession, folks. That's pretty big. You're now going to have managed care companies manage these people rather than the government. That's an insignificant concession, and it's not enough. And then there's my hero, Mike Pence, who put a plan on the table that changes not only how it's delivered, but how the incentives that consumers will have. I don't know if the Obama administration is going to accept that. I really hope they do, because I would love to see a competition between blue state governors and red state governors about who can make this system work. And I don't know why Republicans are so afraid of that competition. They tell me because it's not a perfect block grant. Well, I'm sure that in 2017, when they have 70 votes in the United States Senate and they've doubled their majority in the House, and Ronald Reagan is back in the White House, they can get their perfect block grant. Until then, grow up. Take the challenge and do it. Republicans and Obamacare. Amy Goldstein at the Washington Post says I'm an equal opportunity critic. Silly Republican talking points. And I'm not going to get into a lot of detail on this because I don't have a lot of time. You can go to my blog, and there's a post on selling insurance across state lines, association health plans and risk pools. And you can see the perspective in detail. Let me give you this perspective. The perspective simply. I spend a lot of time with insurance executives, those evil people, you know. I spend a lot of time with them. When I talk to them about selling insurance across state lines and these other things, you know what their reaction is to those Republican market-based proposals, those common sense market-based proposals? To the one, they laugh. I'm not kidding, they laugh. You know, it's ironic that conservatives believe in using the market to make the system more efficient. But the people who are actually the most successful to date at making the market efficient, the winners in the health insurance business, think these proposals are silly. And the second thing I hear from them is, why don't they ever ask us? I'm not lying to you here. Next time you're sitting face-to-face with an insurance executive, ask them about that. Why is it that conservatives don't consult the marketplace they believe in? I have a lot of criticism for the way the Democrats hatched Obamacare and the way it works, and the naivety in what it reflects in the way the insurance markets work. It's just as bad on the conservative side. Now, Burr-Hatch-Coburn is a lot smarter, and it has a lot of common sense ideas, and it has a lot of really good ideas. I will suggest the fundamental problem with Burr-Hatch-Coburn is it takes us back to 2013. And I don't think that's realistic. We're not going backward here, folks. We're going forward. There's a Republican visceral reaction to Obamacare that makes it impossible for them to want to fix it. And part of that is political. We understand it. Which Republican wants to go through the primary in North Carolina saying he wants to fix Obamacare? I mean, we can all understand that. But that is where we're headed, you know. That is where we're headed. We're not going backward anymore. That, I think, opens up a giant opportunity for Democrats to be the party that claims to want to fix Obamacare. When we look at the polls, and I know that you can look at a lot of polls, different conclusions, but I think this one from Bob Lendon and the Kaiser folks is the best one. The bottom line here is it says if you're a Republican, you better tell people you want to repeal and replace, because that's what's popular. But if you look at where the independent voter is, and where the voters are overall when you go to the general election, they want it fixed. They don't want to go backward, and that is the thing to appeal to. There's a Fox poll recently that said that people overwhelmingly vote for the candidate that wants to repeal Obamacare rather than defend it. They forgot to ask the third question: what if they wanted to fix it? And you saw some more reports in the New York Times the last couple of days as they've bored in on this in some of the states, and the same conclusion occurs. The people don't like Obamacare primarily because the health plans are so lousy in it. The product is lousy. But they don't want to go back to the days we had before. They want it fixed. And it'll be the candidates in the long run, I think, that figure out a way to position that will be the winners. So where do we go from here? Obamacare limps along through 2016. The reinsurance programs will protect it. Democrats want to see it play out. The health plan reinsurance scheme keeps them above water. The real rates are going to need to be charged toward the end of this, but that's a few years down the road. Neither side in the 2016 elections, I don't think, are going to have 60 votes in the Senate, even after the 2016 elections. In 2017, a new president in Congress, I think, will be tired of the Obamacare wars, and I hope we'll be ready to move on. I think that's the first opportunity we'll have to get a major course correction here. Now, maybe not. If you bet on Washington agreeing on things and doing bipartisan things, it's always better to bet against it. But I clearly don't see that happening before 2017, and I hope it happens afterward. I do think the Obama administration could really get this thing on track in a number of ways. They don't take my advice. So any of you who advise the Obamacare administration, get out a pad of paper and some notes, and this can be your idea, and maybe you can help them out here. All they really have to do is to broaden the health plan offerings. Jim Jost made a good point this morning. I think he's really on the right track. Do what we did in Part D, the donut hole. Provide benefits up front so healthy people can see value, which is not what we're getting. And please don't tell me there are wellness benefits there. 27-year-old kids don't care about wellness benefits. They're well. You need some benefits that people are actually going to utilize and see value. Then a donut hole, then catastrophic coverage. Go ask the people what they want. A family of four making $59,000 a year has to pay $5,000 in premium. Think about this for a second now, Washington, D.C. $59,000 a year. Do you think they've got $5,000? Do you think they got $400 in their checking account to buy this? For a $2,600 deductible? It's a piece of paper for $5,000. Of course they're not buying it. Of course the dogs aren't eating it. But nobody asked them, and there's lots of opportunity here. The government's probably paying $600 a month in premium subsidies for these people. They'd probably be willing to pay $150 a month in premium. I've now got $650 of premium to give them something, and design deductibles and copays around it. So what I would do is use the existing actuarial floor of 60%, so you don't get junk health insurance plans, and then let insurance companies come up with plans that are more flexible. The section of the Affordable Care Act that mandates the benefits is this long. There's nothing in the statute that mandates the kind of benefits the Obama administration has mandated through regulation. If they back off on the regulations and let people see the number of moving parts in pricing a health insurance plan. There's the premium. Everybody thinks it's the premium. No, it's the premium, the deductibles, the co-pays, the narrow networks, and the benefits. But the benefits are not one of the variables under Obamacare. So what variables do you have left? Premium, deductibles, and narrow networks. Put benefits back on the table and do it in a transparent way. Leave the standard silver plan there. Any insurance company that offers anything else has to have a 60% actuarial floor, and they have to give you a piece of paper, they have to give you a chart that shows you how what you're buying is different than the standard silver plan, and then presume the dogs are smart enough to figure the rest out for themselves. If the Obama administration could do that through regulation tomorrow morning, and they would put this thing back on track for all the other faults it's got. So any of you Democrats, I hope you wrote this down and give it to, because they won't listen to me, but I just told you how to fix it. Now, they got to do it quick, so get that over to the White House fast, because the new rates have to be submitted to the insurance companies have to submit the new rates between May 27th and June 27th. So they got about a month, but they could get this thing back on track. But of course, the reaction you get is we don't need to fix anything because we got to 8 million. Now, I think there's a more fundamental fix to all of this that's fairly easy to do. I suggest, my 25 years in this town, there is remarkable agreement between Democrats and Republicans on health care reform. There is remarkable agreement. Banning pre-existing conditions, insurance exchange, subsidizing low and moderate income people, using the market to manage Medicaid. For Pete's sakes, Jerry Brown is using the market to manage Medicaid in California. There is agreement on doing these things. Democrats are right when they say that Obamacare was built on a Republican chassis. It really was. But Republicans are right when they say the Democrats overregulated the heck out of it and have created lousy products. They're both right. So if we sort of back off and see what we agree on and what we can fix, and most importantly, go listen to the customer, stop arguing with each other and go listen to that family of four making $59,000 a year. They'll tell you how to do this. They know how to do it. So a more robust market for Republicans and a solid safety net for Democrats is a place that people can compromise. The more robust market, I just explained that. It's the same thing I just talked about, giving the carriers flexibility to offer things people want to buy with a floor on it so that we get rid of the junk policies. There were nowhere near as many junk policies in the individual market as liberals would like to think there are. You know, you're looking at the guy with the Cadillac plan, they got a 69% rate increase, they increased my deductibles and they narrowed my networks. So there was junk out there, but it wasn't that much. Better value. By offering more choices, consumers would be able to stretch their tax credits further. The government would be paying the vast majority of this if we had the flexibility. You don't need an individual mandate. I've underwritten hundreds, if not thousands, of employer plans over my career. Not a single one of them had a mandate. Not one. Why did it work? People wanted to buy it. Enough people wanted to buy it. The dogs wanted to buy it because the dog food tasted good. It was a good product. That's why they bought it. Give them the ability to do that. So I'd go with no mandate, no fine, no free riders. The catch is, if you don't sign up during the open enrollment, your pre-existing condition is banned for 2 years. You got to have a no free rider provision in there. Now, don't dwell on the negative here. Don't say, oh, Bob, you got pre-existing conditions back. I do, but don't dwell on the negative. You got to emphasize the positive here, which is if you give people plans they value and they can afford and they appreciate, you aren't going to have people not buying. They will buy. Never had an individual mandate in the employer market because the plans had value. And the only people you're going to catch in the no free rider provision are the people who deserve to get caught in the no free rider provision, because you are giving people affordable health insurance, which is the objective. Make the tax code equitable. I'd limit the deductibility and for employers and the tax exemption for employees to exactly the same thing. And that's the subsidy people are eligible for in the standard silver plan. Whatever, I suppose Republicans don't want it to be a silver plan. We got to call it maroon or something. But create a standard plan that the tax credits are tied to, and whatever we're willing to give people That's the maximum we should be willing to give them through the tax code. That's equitable, and that will make the system more efficient. And it's a solid safety net, because Democrats can look at that and say, well, we're subsidizing this fellow over here. Why should we be subsidizing that fellow over there with tax policy any differently? That's equitable. And Republicans should like it because it makes the market more efficient. Tort reform. Don't just put caps on a dysfunctional system, reform the system. Use the additional money you're going to get by changing the tax deductibility of health insurance to strengthen Medicare. The Medicare cuts in Obamacare are not a terrible problem for Medicare today. This Medicare stuff was overdone. But go ask the Medicare actuary. They're unsustainable in the long term. We got to fix that in the long term, and there's the funding to do that. Implement the Medicare doc fix. You know, the Medicare doc fix bill may have been a bigger bill in terms of changing the financing of American health care than the Affordable Care Act was, because the doc fix bill really creates the incentives to finally move us away from fee-for-service and onto systems that are accountable for the combination of cost and quality. Medicaid expansions. Codify in the law the ability for, so states don't have to go begging a Democratic Health and Human Services Secretary or a Republican Health and Human Services Secretary, codify in the law their ability to have that flexibility. As long as if a state wants to expand to 100% and take the 100% money, fine. They got to prove that their program's going to get as many people in the net. If they want to go to 138%, give them the 138% money, but they got to prove in a reasonable way that they're going to be able to get those people in the net. If they can do that, let them do it. And give them the ability, and let's put competition between Democrats and Republicans and Democratic and Republican ideas. Let's stop arguing about it. Why is everybody so afraid to put Governor Cuomo against Governor Pence? I think it's a fantastic idea. And Medicare is going to have to be a reform down the road. Ron Wyden will kill me for saying this, but I think we need to bring back Wyden-Ryan. And I think in 2017 we will. A platform of guaranteed Medicare benefits, access to the old Medicare plan, but a platform that creates a much more robust market, gives people choices, and makes the market more efficient. I think we will get to that someday. The best hope I've got in 2017 are these two guys. I think Ryan, presuming he's in Ways and Means, and Wyden, whether the ranking member or the chairman of Ways and Means, this is where really exciting things can happen. I'm from Wisconsin. One of the things I hate about liberals is they stole progressive. The progressive movement began in Wisconsin, and it's about people with new, fresh ideas, whether they're conservatives or Republicans. Paul Ryan's a progressive conservative, and Ron Wyden's a progressive Democrat. God bless them both, and I think in 2017, this could be the place where some really interesting things get done. So the Affordable Care Act hasn't cleared the tower. It needs fixing. It was never going to be repealed and replaced. The late surge in enrollment will probably have people saying, we don't need to fix it. This to me is sort of like watching a football game. I'm watching the football game, the two teams are on the field, and somebody fumbles. And the ball is bouncing down the field. And of course, what you do in a game like that is you try to jump on the ball as fast as you can. Obamacare is a fumble. There are really good and important things about it. There are really things that need to be fixed about it. But it's basically a fumble, and it's bouncing down the field. And the Democrats are standing there. They're on one team, and they're saying, we don't have to jump on the ball. We got 8 million. There's nothing wrong. It's not a fumble. And the Republicans are standing there. They're watching the ball bouncing down the field, and they're saying, we don't have to jump on the ball because we're so far ahead, we're going to win anyway. But look at the poll. Look at the Kaiser poll. People want it fixed. I think the electorate is waiting for somebody to jump on the ball and take us to the next step. And I think that's where the political opportunity is. I know from an actuarial and financial standpoint we've got to do that, because this is not going to work the way it's working right now. But I also think the first real chance for reform or change, the next iteration on this journey toward health insurance reform and hopefully health care reform, probably doesn't come before 2017. I think the Republicans could yet see the issue back to Democrats. I was watching Mary Landrieu the other day. Go watch Mary Landrieu. She's figured this out. I think more and more Democrats are going to figure out how to take this issue over, and Republicans better pay attention, because this election is not over. We got a couple of minutes for questions. I think Jim is going to moderate. I'll be happy to answer as many as I can.
Well, it generated a lot of questions. Let's start over here with Jeff. Go ahead.
Yeah, good job, Bob. Gutty talk. You advise health insurance executives, and you look forward into 2014. There's a lot of ominous stuff there. The soft caps, the political caps on their rate increases that you talked about, the fact that health costs seem to be reaccelerating, and that there's a very good likelihood that that 30% of the people that ate the dog food are going to be sicker than the folks that, didn't.
Right.
How is it that two of the big publicly traded plans, WellPoint and Aetna, raised their earnings guidance for 2014? How do you reconcile those earnings raises with the ominous forecasts?
Obamacare, the Affordable Care Act, doesn't move the needle on health insurance company earnings. First of all, it's a tiny percentage of what they do. You saw the chart. I mean, I swear, the Federal Employee Health Benefit Plan is more revenue than Obamacare is going to be over the next 3 years. Okay, that's number one. Number two, you've got the 3 Rs, the reinsurance provisions. The reinsurance provisions don't mean the insurance companies won't lose money, but they're only going to lose a couple of points on premium. All right, that couple of points on premium on that small sliver of business is not a material impact on their bottom line. They are much more worried about Medicaid. And the big issue here is, boy, this is a terrific opportunity for Medicaid expansion, and they're much more worried about those Medicare Advantage payments. The Medicare Advantage is the biggest part of their profits right now, and that's one of the reasons they behaved so well in October and November. So, and somebody said the other day, well, Blue Cross of Iowa and South Dakota are getting back in the business, and United might be going into Connecticut. That means it's working, right? Well, I'm not going to tell you what those guys were thinking. I don't necessarily know what those guys were thinking, but I'll just leave you with this. If I were back running a health insurance plan in the good old days, and I were confronted by all of this, I might just wait out on the exchanges the first year, let the sick people sign up with the other guy, come in the second year, and the sick people are already with the other guy. So there are a couple of different interpretations for that move as well.
I'll take you, and then I'll come to you.
Hi, sir. My name is Sharon Bovat, voice of a moderate. In the mid-'80s to early '90s, I had Kaiser in Northern California, and my hope for Obamacare would be something similar. It was what you had offered or talked about, the healthy options. It was very easy, very affordable, did not have a high deductible. Do you ever see a plan like that? And then also quickly comment on single payer.
Sure.
Thank you.
And you and I share a past. I was running a health insurance business in Los Angeles in the mid-'80s, and so I know Kaiser very well, and I have enormous respect for Kaiser and what they've always done. But yeah, I mean, what we're talking about are crafting health plans that provide real tangible benefits that, by the way, are relatively inexpensive. If I'm willing to pay for somebody to go to the doctor for the strep throat, there got to be co-pays, so you don't have people overutilizing and not going to the doctor when they need to wait the extra day to make sure it's not the strep throat sort of thing, or go to the nurse at CVS that can give them the strep culture. So you have to have incentives for people to think about how they're going to utilize. But there are ways to create really valuable plans. Part D is a good model, actually, because there's no individual mandate in Part D. They offered it the first year. Did 30% sign up? Probably 70 or 80% signed up the first year, didn't they? Why did they sign up? And Part D, by the way, is a catastrophic health insurance plan. Part D is a few benefits up front, a big donut hole, and catastrophic insurance. And the people love it. That was a product that hit the mark, unlike these products. Now, your second question was single payer. And in what context? Do I think there's going to be one someday? Or?
Well, I mean, I believe that if there's another recession, we will be going to single payer.
Yeah.
And I wanted your comments.
Well, some people question why particularly my Republican friends that are really mad at the insurance industry for cooperating on Obamacare. They forget Obamacare is a monopoly. What choice do they have? But when you talk to insurance executives, they really do want Obamacare to work. I mean, who's worked harder to make Obamacare work than the insurance industry? And been more cooperative and gotten slapped around quite a bit by their big customer, the federal government. Why do they want to make it work? Well, it's 50 million people in the market, small group and individual. That's a good reason. But the other reason, I think, is they don't have a lot of confidence in Republicans when it comes to health care policy. So if Obamacare blows up and fails, and it's just this god-awful mess, it looks like the New York or New Jersey individual insurance pool did in 2013. It's just a terrible, terrible mess. And will Republicans grab this thing by the horns and deal with it? They haven't had a history of that. They like to sell insurance across state lines, but they do not get terribly serious in the Congress. I've got some friends in some of these think tanks, obviously, but in the Congress, they don't get terribly serious about health care reform or health insurance reform. And so what happens the next time the pendulum swings and Obamacare is a disaster? Tim, what do you think of it? Should we just go direct to single payer? Just say yes, because that's what you say to me otherwise. Yeah, but you think we should. So that's what's going to happen. We're headed for single payer. So we make Obamacare work in the market, or we're headed for single payer. I don't think there's any question about that.
Paul Vanderwater here in front.
You're going to live a long life, Tim. Don't trust me. We'll see the cycle through together.
So the crux or a key part of your argument is that because of the benefit requirements, plans are having to spend more for benefits people don't want, and therefore they're also having to add features that people also don't want, like narrow networks. But I'm wondering in particular, what benefits do you think are required that are adding substantially to the cost, and is there really enough money in that sort of thing to go and allow for less narrow networks or other improvements?
Yeah, and that's what Tim always challenges me as well. It's not that you, again, go back to the section in the law that has the benefit requirements. You have to have a hospital benefit. You have to have a doctor benefit. You have to have a lab benefit. You have to have a prescription drug benefit. But you can have a prescription drug benefit with a threshold deductible. You can have a hospital benefit that pays 70% of the first 30 days and 100% of the next period of time. It's not that you're going to take any benefits away. It's that you're going to do different copays and you're going to do different things with what can be delivered on those benefits. You can restrict certain drugs if generics and alternatives are available. In other words, there's an enormous flexibility in how you provide those benefits. Employers provide 70% actuarial benefits, but they do it very efficiently and for a much lower cost. So there are a number of variables in the way you package the benefits. And don't get me wrong, this is a zero-sum game. You take something away when you do that. And it's a question, but I think the difference is healthy people want different things than sick people want. Everybody wants catastrophic insurance because the healthy person is the person in the motorcycle accident next week. But they want different things on the upfront. And there's enormous numbers of things you can do. The Part D drug benefit's a good example. People say, well, you're going to get anti-selection. Look at the Part D drug benefit right now. You can go on the computer. CMS runs a computer program. You put in your drugs and you figure out which plan pays you the best and you pick that one. If that's not anti-selection, I've never seen anti-selection. Yet that is a very efficient plan. We can manage anti-selection. There's always been anti-selection. Yes.
Hi, thank you. I'm Seth Truger. I'm an emergency physician and health policy fellow at GW. You mentioned a lot about how only 30% of the dogs like the food right now. And one of the things, only 30% of the dogs like the food.
Okay.
We're only seeing a small percentage of people who were previously uninsured buy.
And we don't know that the 30% like the dog food. It was just a monopoly. They only
eating
buy
the
it there.
food.
Yeah.
They may not like it. And
it's the only dog food they were served.
Right, exactly.
And they're hungry.
And Jim touched a bit on the point about churn. We see churn in the Medicaid market. We see churn in the uninsured pool. We see churn in the individual market.
Right.
And my question is, the 67% or 70% of people who aren't, who were previously insured are tomorrow's uninsured, but for the insurance. Does that mean that are the numbers necessarily that scary because perhaps, we're mitigating the future uninsured by making sure that the people who are currently uninsured now still have insurance later?
Yeah, they're fair because the people who are in the market today, 30% of them bought it, and there's no reason to believe that the people will be in the market tomorrow afternoon, 30% of them won't buy it. I mean, you got a pretty, you want to do the Kaiser poll, you want to do the Gallup poll, you want to do the Rand poll. You just did a poll of 29 million people eligible for the exchanges, and 30% showed up. That's a pretty good poll. That's a pretty good predictor of future performance, isn't it?
Laura there in the back. Yeah.
Laura Truman with the Heritage Foundation. Wanted to ask about the back end. So we were assured everything was going to be fine about Obamacare, and then the curtain lifted and there was a lot of disasters. Then there's this mysterious back end. And what are you hearing from insurance companies about those systems working, and are we going to have some shoes drop?
Well, first of all, the big problem was the 834 transactions that came from the feds to the insurance companies on enrollment, and they are generally working okay. You're still getting what we would call unacceptable error rates for high volume performance, but it's you know, it's in the single digits, low single digits now. It's something the carriers are able to sort of keep their heads above water on. I mean, it's not what it should be, but it's workable. The rest of the back end is like the ability of the feds to pay the insurance companies their premiums, the billing system, if you will, and the ability to do reconciliation, to compare the lists between the insurance companies and the feds. There's a meeting next week between CMS and a number of insurance companies that they're focusing on to talk about some of the issues for what the back end should look like. The back end is not even, it's not close to being able to be tested yet. I'm hearing if we're lucky, we'll have the back end by September. That would be 1 year later than, it should have been tested by September of last year. And folks, don't discount this. I mean, you know, we're talking about what our insurance companies can do with the rates. The insurance companies don't know what their premium is. You can't do a medical loss. They know what their claims are. They have no idea what the premium is because they haven't been able to do a reconciliation. But one of the funny thing is, one CEO told me, you know, the good thing about the Affordable Care Act, we send them a bill for what we think they owe us, and they send us the money. I mean, you've got, what are the subsidies worth a month? $10 billion? You know, we're now into the 4th or 5th month of the insurance companies billing $10 billion a month with no backup and no reconciliation. Now, let me assure you they're good for it. But we've got the mother of all reconciliations coming. And this is one of the problems with the 8 million. You know, you live by that sword, you're going to die by that sword. And I wouldn't be pushing that too hard.
I think this might be our last question here. Actually, we're running up against our deadline here. Go ahead, Dennis.
Well, Bob, it's just a follow-up question. If the insurance companies aren't actually getting paid, the 8 million go out and use the benefit, who's on the hook? I mean, are providers going to be rendering care to people that aren't
Well, this is
covered?
a big controversy.
I mean,
yeah.
what
because-
happens?
Yeah, the provider ends up being on the hook, not the insurance company. If the first month's payment comes in, the insurance company can't take them off the system for 2 more months. So they got 3 months with 1 month's payment. If the person goes to the doctor and the consumer doesn't pay their premium in the 2nd and 3rd month, the insurance company can tend or suspend claim payment, but the doctor's providing treatment. So I was with some physicians yesterday, and one of the big questions from one of the practice leaders was, or one of the points he made was, you know, he said one of the big differences with Obamacare is we're collecting up front. Because first of all, we're not sure if they're going to be covered or not. The second thing is these deductibles are so darn high, particularly for specialists. You know, just because this poor person's got insurance, but they got a $2,000 deductible. I mean, they've got catastrophic insurance. The specialist isn't certain that he or she is going to get paid. So there's a lot of trauma out, and you know, and I don't know how I would have done that differently. I mean, that's just these are the complicated moving parts. So I don't mean to say, oh, Obamacare is all screwed up. I'm not sure how I would have done it differently. But it's one of the things that clearly has to be fixed, and it's going to be somewhat of a mess. And the fact that we don't have a reconciliation ultimately hits the provider more than the insurance company, because the insurance company just, you know, they're going to get their money. But the provider isn't necessarily going to get their money.
Spoke too soon. We actually have time for a couple more questions. I saw one over here, yes.
Rick Barton with the Charles Koch Institute. On state Medicaid expansion, given the likelihood that the Obama administration will not hold to that 90% match rate, would it not be, from a fiscal standpoint, irresponsible for governors to accept that expansion at this time?
So here's the question I often get from my conservative friends. The federal government is paying 100% of the Medicaid expansion in the first year, and it drops to 90%. When it drops to 90%, the state is on the hook for a lot of money. And so don't tell me that the state isn't on the hook for the cost of Medicaid expansion, because the first few years are just the teaser years, and they're really going to be on the hook for 10%. My response to that is simple. Mr. Republican, you're telling me that you don't know how to make, with market-based reforms, the Medicaid market 10% more efficient? You're telling me you can't sweat 10% out of this system? You're telling me you can't run your Medicaid program for 90 cents on the dollar, and Cuomo's running it for 100% on the dollar? Put up or shut up.
John Grant.
Not that I have an opinion on that.
If I recall, one of your...
Some of us have to believe in the market, even though people who claim to believe in the market say they believe in the market. Some of us actually spent their life in the market, and we believe in the market. I can manage Medicaid in any state for 90 cents on the dollar, and most of my peers can.
I just wonder if we get your comments on, in the long term, after the 3 years, what does risk adjustment look like in the long term, especially if you loosen up the benefits offerings as you've recommended? Do we stay with the Medicare Advantage type system, or what? Because the risk selection the anti-selection is still a big problem. So
what does risk adjustment look like in 2017?
And beyond.
Yeah, well, according to the statute, it's the old market. You know, the 3 R's go away in 3 years.
Oh, 2 of the 3 R's.
Oh, risk adjustment stays. I corrected, yes. Risk adjustment stays. And all that means is that if you're a health plan unlucky enough to get the sick people, it self-adjusts, okay? And that's fair enough, because you've got some players that are too small, okay? But the training wheels, the subsidies go away. So, you know, what you have is the regulated market, and that's what insurance companies are used to now. That's what they've got in Part D. That's what they've got in Medicare Advantage. You know, their biggest customer is the federal government now, and so that's part of life.
The reason I mentioned Medicare Advantage is there's still some anti-selection. We still have, we'll give you a free membership and stuff like that, gym membership, stuff like that.
Yeah.
I mean, can we improve that?
Yeah. No. Clearly, the risk adjustment formula. And that's why you hear all these people say, well, these insurance companies are really nothing at the core more than cherry pickers. They're going to figure out to cherry pick anyway. Read the law. I mean, it's a zero-sum game on that count. You can bring all the healthy people in. It's not going to do you any good. The sustainability of the law and the sustainability for the insurance industry is getting an adequate spread of risk for the Affordable Care Act. That's what sustains the law. You can be the best cherry picker in the world, and believe me, I was a pretty good one in 1984. But it's not going to do you any good today. And remember that the next time you talk about all these insurance company cherry pickers and the way they're going to screw it up. Remember that section of the act. Thank you, Tim.
I think I'll use the prerogative of the moderator here and ask my question, which is, you were very adamant about the Burr-Coburn-Hatch going backwards before it goes forwards. But is it not possible to enact something like that with a transition for?
Yeah, and you and I were talking about this on the side. I think it's a semantic thing that Republicans got a real problem with. I mean, I think Republicans have got to figure out how to get around this repeal part of it. And any legislation that you pass to fix Obamacare is, in a sense, repeal and replace. But the perspective has to be going forward. Some of the problems with Burr, Hatch, and Coburn, and I have a great deal of respect for many parts of that bill. I think that is a serious Republican bill. I wish they had proposed it in 2009. Because now if you pass Burr, Hatch, Coburn, you're going to eliminate the Medicaid expansion. Now, 30 states will have expanded Medicaid in the next year or so. That's 60 United States senators in the Senate. You're going to eliminate the Medicaid expansion?
Well, they replaced the Medicaid expansion with a uniform credit that everybody would have insurance under the system.
So
I would remind you that Coburn proposed this in 2009, and it was altogether ignored.
But what we're talking about is going forward, and that is a
Sometimes to go forward, you got to do a lobotomy first, and then.
Well, and I think one of the problems Republicans have got in this election is they've got to get off they're going to get hung with the notion that they want to go backward, and that is going to be, I think, the wrong political move to make come November. It may win some Tea Party primaries, but that's going to be a terrible thing for them to have to carry come in November, because the vast majority of the American people want this fixed. They don't care about all the conservative and Republican criticisms and the backroom problems and there's no reconciliation system. They want it fixed, and that's what people have to focus on. And Burr Hatch Coburn has a lot of really good ideas in it.
I think we'll let that be the last word. Join me in thanking Bob for provocative